Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar. Organized by AMOGS Emergency Committee with Northeast Societies, and this is episode 6. Let me introduce the MOC and coordinator of today's webinar, Dr. Monica, ma'am. Ma'am is the consultant obstetrician and gynecologist at Mangalore.
Saiti, it's okay, Saiti. Let's move forward so that we don't waste time.
Yes, ma'am. I welcome you, ma'am.
Thank you so much for the kind introduction. I welcome all the esteemed faculty members today for the 6th episode of the AMOGS Emergency Obstetrics Committee with the Northeast Societies. This webinar is a brainchild of none other than Dr. Sneha Bhuyar Madam, who is the chairperson of the AMOGS Emergency Obstetrics Committee for the current 2 years. She has set the bar for the AMOGS Medical Disorders Committee in the last 2 years so high that everybody looks forward to these academic sessions because they have a very great take-home messages. I would invite everybody for the lamp lighting ceremony. Saiti, can we have the audio, please? Thank you. I would now introduce Dr. Sneha Bhuyar Madam. She was the Foxy Breast Committee chairperson. She's a part of the managing committee of the ICOG current body. She was the past chairperson of the Medical Disorders Committee, and right now she is the chairperson for Emergency Obstetrics Committee. She's also the president of IMA Yavatmal. She has many accolades to her credit. I welcome you, ma'am, to address the August gathering.
Thank you so much, Monica, for the kind introduction. A very good evening to one and all. At the outset, I would like to thank the dignitaries, especially respected Dr. Gokul Das sir, for accepting the invitation. Right now, he's busy with the Puttaparthi Foundation meeting, but he will join soon. Respected Dr. Muralidhar Pai sir, a guest of honor today, Dr. Ajay Mane, Foxy Vice President, and Dr. Hafizur, who is the Governing Council member, and of course the Professor of Obs-Gynae. I welcome all the esteemed faculties, the chairpersons, and of course, the panelists for this program on behalf of my AMOGS family. President Dr. Kiran Kurtakoti, Secretary Dr. Bipin Pandit, and the immediate past president and my mentor, Dr. Rajendra Singh Pardeshi sir. I welcome all of you for this program. I welcome my dear friend and coordinators for today's program. The convener first, Dr. Prerna Keshan, who has helped me a lot for planning and coordinating with the people. Dr. Monica Singh, Monica Umbardand. I'm so confused with all the three Monicas. And of course, the coordinators for my today's program. I thank all the esteemed, faculties and panelists, chairpersons. I thank all the societies of Northeast for accepting the invitation. I can see my dear friend, Dr. Indrani Roy, who was the, East Zone coordinator for my committee. So welcome, dear Indrani. And I welcome all of you here for this program. I'm still missing Dr. Priyanku Roy, who is the moderator along with me, the chairperson for Public Awareness Committee, Foxy, and of course, my dear friend, Dr. Charu Bapai, who is the Foxy Breast Committee chairperson. I can see Dr. Brajbala and all the others. I welcome all of you here. And with this, I just pray to God and have God's blessings. And I, have the blessings of our respected seniors. So I initially invite respected Dr. Muralidhar Pai sir for his blessings and of course words of wisdom. I don't think anybody here in this August gathering needs the introduction for Sir. Sir is, the Dean of Sikkim Manipal Institute of Medical Sciences and Professor of Gynae. 36 years of academics, 20 awards, 15 international fellowships, 207 publications, 2 textbooks, and 785 guest lectures. I'm sure it's uncountable and unstoppable, sir. Over to you for your precious words and guidance, sir.
Yeah. Thank you very much, Dr. Sneha, and good evening, everyone here. It's always a pleasure to be part of the AMOGS meetings, especially that are coordinated and conducted by Dr. Sneha, because she has been a very good friend of mine over last many years, professionally as well as otherwise, merely because of her hard work and dedication to the cause. So I cannot refuse whether I'm a speaker, panelist, guest of honor, or even an audience. So thank you so much for inviting me as a chief guest. This is a great honor, especially in the presence of greats like Dr. Rajendra Singh Pradesi and also Dr. Kiran Kurtakoti and Dr. Bipin. And today's seminar specially dedicated to Northeast, though I am from South, I have become a Northeast person now. And I really am thankful that you have dedicated this entire seminar for this particular region, which is very much required. And the topics that you have chosen, especially the emergencies like postpartum hemorrhage, the and the accidental hemorrhage, as well as the near miss. Near miss is very dear to me, this subject. And I'm sure Dr. Sneha and Dr. Priyankur will be doing an excellent moderation of that particular panel. I'm looking forward to uh, listening to that particular panel. And a good friend of mine, Dr. Parag Binwale, is going to talk on the abruptio placenta. And then the PPH lady of India, who has made herself distinguished in that particular aspect. And my own good friend, Dr. Sheila Mane from Bangalore. She'll be talking on management of PPH. So I'm really happy to be a part of this very erudite speakers and the panelists. Thank you very much. Wish you all the best for this. Thank you.
Thank you so much, sir, for that words of wisdom and guidance as well. Thank you so much for your appreciation. Gokuldas sir has not joined, so I will hand over the forum to Dr. Prerna Keshav, who is the convener, to introduce and invite guest of honor. Over to you, Dr. Prerna. Prerna, I would like to introduce you, Prerna. Is a very dear friend, and of course, she is now the Masters in Cosmetic Gynecology, and of course, very leading obstetrician. She has so many national and international publications.
Thank you, ma'am. Thank you.
Position also she has held. I'm sure we are looking forward to to have you at the national forum as in the organization. Over to you, Dr. Prerna.
Thank you, ma'am, for your wonderful words. Wishing you all a very good evening, and it's such an immense pleasure to have you all amongst us with this AMOGS Emergency Obstetric Committee meeting with the Northeastern Societies. So much so required to bring the entire National Forum to our Northeastern states. It's such a pleasure, Dr. Sneha Bhuyar, madam, have done this brainwave for us. Thank you, ma'am, for keeping us in the loop. So presenting before you our guest of honor today, Dr. Ajay Maine, sir, is the Vice President FOXI 2024, the State Representative of AMOGS 2426, member of NMC and PCPNDT wing of the Government of India, medical legal consultant for over 18 years now, and is the chair of various reputed national organizations with different capacities, and the past president of Aurangabad OBGYN Society, and has a number of laurels to his credit. We welcome you, sir, amongst us, and we are really honored to have you in this August gathering. We really welcome you to have your words purged of wisdom and to address the August crowd. Dr. Ajay Maine, sir.
Thank you. Thank you, Prerna. She is such a nice lady that in spite of saying so many times, she has completely read the biodata, which we could have skipped. Okay, no problem. Thank you, Prerna, for that good words. Respected Pardesi sir, my friend Kiran, Vipin sir, and my sister, Dr. Sneha from AMOGS. First of all, I convey my gratitude to Sneha ma'am for including me in this webinar, and which is my favorite area, that is Northeast. I have gone so many times. I have gone to Hafizul's place. I have gone to because Gokulda is our favorite person due to Rajan Singh Pardesi sir, and he always say ki these are lovely people. They are clear by heart, not by mind. See, the love is true. In diplomatic word, this true love is very rare, and that is given by these Northeast people. So I like them very much. So, and today Sneha ma'am has taken all the PPH and all practical obstetric emergencies which are faced by all of us. If somebody says, no, 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 we have not seen such case, we have not seen a near miss case, then two things. One, the person who is saying that is not either practicing or he is saying lies. Two things. Okay, so every person has to face this situation, and see, periodically drilling or periodically academic inputs or periodically teaching will be the only remedy to save from such incidences. And that's what the Sneha madam is doing. So I congratulate Sneha ma'am. The topics are very nice. The speak from Northeast and rest of the India she has. So I congratulate. Personally, I congratulate Dr. Prerna, Dr. Shatabdi, and Dr. Monica Umbardhan, who is continuously and untiringly working for all the webinars. They are such a nice academic fellows. They have their own practice. In spite of that, they work for the society. Society means all the gynecologists and the obstetricians who are learning from this series. So I congratulate all of them. And lastly, I urge all of you to kindly help my sister going to Foxy as a vice president. Kindly vote for Sneha ma'am as she is contesting for this year. So thank you very much for calling me. And best
Thank
luck
you,
for the
sir.
webinar.
Thank you so much. Thank you.
Thank you, sir, for enlightening words. We are really a treasure always to hear you speak. And with this, we move on to our next guest of honor and a very beloved friend of ours from the northeastern India itself, Dr. Hafizur Rahman. He's a name when it comes to the northeastern societies. So he's the ICOG Governing Council member 21-25 and the former head of the Department of OBGYN SMIM, Sikkim Manipal Institute of Medical Sciences, Gangtok, and the founder and current secretary of Gangtok OBGYN Society, and has various research publications of national and international repute to his credit, and has been bestowed with various Foxy awards, including the Foxy Future Award 2017, and has been the organizing secretary of the East Zone UR Foxy 2018, very successfully conducted. We welcome you, Dr. Hafizur Rahman, for this wonderful meeting, and we look forward towards your pearls of wisdom to the August gathering. Dr. Hafizur Rahman, sir. Do we have him here?
I think Hafizur is not there.
Yeah, I can see his name here, but the video and audio.
Maybe we can take once he joins in. Maybe we can take him.
Yeah,
Ma'am, he is there.
you can call him, please.
Yes, ma'am. I'm just calling him.
So over to you, Sneha, ma'am.
Okay, you can take blessings from Rajan Singh Pardesi sir. He is there.
Yeah, I'm doing it. So, is it there? Yeah. So, we being the host family of AMOGS, and my mentor, respected Dr. Pardesi sir, who is the past vice president of Foxy, and of course, I mean, so much to learn from him. He was a past chairperson of Food and Drug Medical Surgical Committee, and of course, so many awards. He has got 28 paper awards.
It's okay.
Yes, sir. So
Yes.
over to you, and we are eager to listen to you and have your blessings.
Thank you, Dr. Sneha. Respected Chief Guest, Dr. Gokul Das sir, Dr. Murlidhar Pai sir, and guest of honors, Dr. Ajay Mane, Dr. Hafizur Rahman, and our ever-active AMOGS President, Dr. Kiran Kottakoti, office bearers of AMOGS, and with Dr. Sheila Mane, Dr. Charulata, Dr. Parag, Dr. Priyanka Rao, Dr. Monica Uberdan, and friends. I am feeling proud and honored to be a part of this program with Northeast societies. AMOGS has extended its hands with Northeast societies for the betterment of women's health. With their seniors and friends like Dr. Ritu Nath, Dr. Pranav Fukan, Dr. Indrani Roy, Dr. Prerna Keshan, Dr. Shatabdi Day. I am feeling proud and honored and like attending again NeoGiscon, AISUG and East Zone Yo Foxy at Shillong. I cannot forget the warm hospitality at NeoGiscon, East Zone Yo Foxy at Shillong and AISUG 2005, 20110 in Guwahati. I wish to congratulate Dr. Sneha Bhuyar, Dr. Prerna Keshan, Dr. Shatabdi Day and Dr. Monica Umbandan for organizing such an academic and practical webinar on PPH, APH, which will help in reducing MMR. I wish every success to Dr. Sneha Bhuyar for her future endeavor in Foxy as Vice President Foxy in this future election. I wish every success to, I think Dr. Brajbala is there. I wish every success to Dr. Brajbala Tiwari for her future endeavor in Foxy as chairperson of Environment Health Committee in this future election. Thank you. Thank you so much for inviting me. Thank you.
Sir,
Wishing every success to this webinar. Thank you.
Thank you so much, sir. Thank you for your blessings. Thank you so much for your precious words also. So I can see Dr. Hafizur here still, but
Ma'am, actually, he's traveling. He said he's got disconnected and he will take another 2-3 minutes to rejoin.
Okay.
So
okay.
we
So
can
by
take his
yeah, once he joins. So thank you so much, respected chief guest, Dr. Muralidhar Pai, for taking out time, your precious time to join and to bless me. Thank you so much, respected sir, Dr. Rajendra Singh Pardesi, for being there always to bless me and to guide me. Thank you, Dr. Ajay Mane, my dear brother, Foxy Vice President. We are proud of you. And you are always there to support me. And of course, Hafizur, in spite of being so busy and traveling, he's with us and he will be joining soon. So I thank all the esteemed speakers, Dr. Sheila Mane, Madam, Dr. Parag Piniwale, our dear friend, and all the panelists and the chairpersons. I think Priyankur is yet to join still. But I thank all of you once again, and without much ado, I hand over to Dr. Shatabdi and Dr. Monica for taking this program ahead with the academic session. Thank you so much once again.
Thank you, ma'am. With this, we declare that the inauguration is now over, and we start with our scientific session, that is management of PPH by none other than the PPH lady herself, Dr. Sheila Mane, madam. I request to both our chairpersons, Dr. Hello? Yes, ma'am?
Has she joined? I could not
Yes,
see.
ma'am. I can see her, ma'am.
Okay. Go ahead.
Dr. Charulata Bapai, madam, is the director of GEMS Hospital and Endoscopy Center at Pune. She is currently the chairperson of Study on Female Breast Committee, FOXY, and she is a clinical secretary of the Pune OBGYN Society for the year 23-24. She is also honorary consultant at Dinanath Mangeshkar Hospital. She has many accolades to her credit, including... Yes, ma'am. Thank you, ma'am. I also would introduce our next chairperson, Dr. Ritunath sir. He is a principal consultant at STNM Hospital, Gangtok, Sikkim. I would request Ritunath sir to please introduce our faculty, Dr. Sheila Mane madam, and Charu madam to please sum up the lecture at the end of the talk, ma'am. Ritunath sir, can you please introduce Dr. Sheila ma'am?
Yes, Dr. Sheila Mane, are you listening to me?
Yes, sir, you are audible.
You are audible. Welcome, Dr. Ritunath sir and Dr. Charu Bapai, chairperson. Please go ahead.
Okay. Dr. Sheila Mane, as I know, is the prominent gynecologist and expert in fetal medicine and infertility. She is going to deliver a lecture. I'm audible?
Yes, sir.
Yes, no problem.
Okay, I'm traveling because it is
no problem.
difficult.
I think
Maybe
Madam can
network
start,
won't be.
sir.
Okay.
Ma'am,
In between the network,
Without
and can
Yes.
start
going,
a talk.
ma'am, actually, Sheila Manama also has got disconnected. She's joining again. I just spoke to her,
I
ma'am.
can see her. I can see
no
her.
problem.
Yes, ma'am.
Madam, welcome.
Anyway,
Ma'am, please unmute
I
yourself.
I'd like
Yes,
to welcome her
See,
for the
actually, my
deliberate.
laptop is just going to come. Sir, sorry, sir. Well, just a minute.
It's
If
fine, it's
you
fine.
can give me some time and Parag can start his talk. Is Parag there?
Yes, Sheila, I'm very much here.
Yeah,
Yes.
sorry, I have joined now. So, Parag, if you can start and I'll take the next talk.
Sure, no problem.
Okay.
Is it okay, Sneha? My laptop, some problem. So, I have joined from the phone. And so
Sheila,
you
don't
can
worry.
introduce
I'll
Parag and
take the
I'll take
first
the next.
lecture. Yeah, I'll take the first lecture. You can take next one.
Okay, thank you so much. Yeah, thank-
Sahidi, can we have sir's CV so that Ritu sir can introduce him?
Okay, ma'am.
Yeah.
I think Ritu sir is traveling, so he cannot.
Charu ma'am, can you please introduce sir so that we can start, ma'am?
Sure. So,
Please
you
do
know,
that.
it is
It's
man
very difficult
proposes,
for me to in a motion, you know.
it is
So-
man proposes, God disposes. So what better opportunity for me than to, introduce and welcome Dr. Parag Biniwale as our speaker. We go a long way back, probably right since 1990-91. And he has been the one who has handheld me and taught me so much, not only about obstetrics and gynecology, but about POGS, that is my parent organization, and FOXY, and of course about so many other things. So, Dr. Parag, indeed, my proud privilege to welcome and invite you for your talk. He's obviously a very, very well-known and a very well-loved Foxian who has worked so hard, not only for Foxy, but now for ICOG also. He's a senior consultant from my very own city of Pune. He's been a PG teacher and unit head at Kamla Nehru Hospital, which is a very busy and bustling hospital. He's the chairperson elect of ICOG, and we have many, and I'm sure he has many things lined up for all of us for the next year. He has been my president.
Thank you, Charu. I think that's enough.
Wait. No, you have to hear all this. Where Sneha and myself did our BreastCon, and it was a big success. He has been the president of the Menopause Society of Pune. He's been the peer reviewer of journals. He has got to have so many articles, and still he's so humble and grounded. So Parag, such a pleasure to know you as a friend, and of course as a co-gynecologist from the city of Pune. Welcome, Parag.
Thank you, Charu. Good evening. I bring greetings from AMOGS, and as a national coordinator of AMOGS, it's indeed a pleasure to visit virtually the Northeast societies. I've managed to visit few of them like Guwahati and Dibrugarh, Jorhat, Gangtok, and of course Shillong. So thank you, Sneha, and the entire team for giving me yet another opportunity to interact with the friends of Northeast. All right, in next 15 minutes, I'm going to talk about one problem which we as gynecologists or we as obstetricians don't want to face, and that is placental abruption. Now, all of us know that placental abruption or abruptio placentae refers to partial or complete placental detachment prior to the delivery of the fetus. And the diagnosis is typically reserved for pregnancies over 20 weeks of gestation. So any woman who comes with history of pervaginal bleeding beyond 20 weeks, the first thing that comes in our mind is placental abruption. So abruption is a significant cause of both maternal morbidity and neonatal morbidity and mortality, especially when it occurs at preterm stage. Placental abruption complicates about 2 to 10 per 1,000 births, and it is really significant because of its impact. Now, typically, when a patient is brought to us with history of vaginal bleeding, she may or may not have abdominal pain, but then when the abdominal pain is there, many a times it is associated with hypertonic uterine contraction. The uterus is tender, and generally the fetal heart rate pattern is non-reassuring. There are so many risk factors which may be responsible for placental abruption. Now, if you look at the chart very, very carefully, some rare causes which we may not even think in mind, like cocaine and other drug use, abdominal trauma or accident, and polyhydramnios are responsible for placental abruption. All of us are well aware about the relation of placental abruption with preeclampsia and eclampsia, premature rupture of membranes. But let's not forget that if a woman has abruption in the previous pregnancy, she is at a very high risk of developing abruption in the next pregnancy as well. So can we predict placental abruption? Now, abnormalities of maternal serum biochemical markers used for Down syndrome and neural tube defect screening carry up to a 10-fold increase in the risk of subsequent abruption. So these markers would include alpha-fetoprotein, human chorionic gonadotropins, the levels of which are raised, decreased levels of PAPA, that is pregnancy-associated plasma protein A, or unconjugated estriol, and inhibin less than 5th or more than 95th centile. And these abnormal values are not associated with any fetal abnormalities. So when such confusing report is here, we have to start thinking that this particular woman may land up in placental abruption. But the severe abruption is something which really haunts us because the mother is at risk. She may land up in DIC, hypovolemic shock. She does require a lot of blood transfusions. Rarely hysterectomy is required. She may land up in renal failure, and it is known fact that she has a high risk of dying. The fetus generally is affected first because of its non-reassuring status. There could be growth restriction and even fetal demise. And the newborn many a times faces challenges because at times it is born too soon. It is generally a small for gestational age baby and has more risk of dying. So it is important that we monitor these patients very, very well. So whenever we get such a patient, the first and foremost we have to do is monitor the fetal heart sounds continuously, because we know that the fetus is at high risk of becoming hypoxic or developing acidosis. We have to ensure that intravenous access is secured. A wide bore cannula number 16 has to be there. We may have 2 lines, if not 1, especially in women where we are suspecting moderate or severe abruption. If they come with heavy bleeding, hypotension, tachysystoly, uterine hypertonicity and tenderness, we really have to be very, very vigilant, and we also have to act really fast. We must administer crystalloids, preferably Linger's lactate, to maintain urine output above 30 ml per hour. Close monitoring of maternal hemodynamic status is important. So we must keep a chart of heart rate, blood pressure, urine output, and even blood loss. Assessment of multiple parameters is important because normal blood pressure may mask hypovolemia if the mother has chronic hypertension or pregnancy-associated hypertension. And we know that these are very important risk factors for placental abruption. So in patients who may have severe abruption, urine output should be monitored closely, but a bladder catheter is not necessary unless the patient is hemodynamically unstable or if we are contemplating a C-section delivery for her. Sending lab for certain investigation is extremely important, and we should do it ASAP. Complete blood count, including platelet count, blood grouping and typing, and we must cross-match at least 2 or 3 pints. Coagulation studies are important, so we must get the prothrombin time, activated partial prothrombin time, etc. Liver chemistries are important because we may be dealing with a woman who has preeclampsia or HELP. So here we may have elevated liver enzymes in the reports. Doing urine albumin is important, and of course, we must get renal function tests to assess the functionality of the kidneys. It is always important to quantify blood loss because this is something which we obstetricians many times fail. So moderate and heavy bleeding can be measured in variety of ways, and there are various means of doing it. Number one, collecting blood in a graduated measurement containers, including drapes and calibrated pockets. Of course, there are now drapes available where the entire amount of blood lost can be collected and counted easily using visual aids. For example, posters or pocket cards that would correlate the size and appearance of blood on any specific surfaces. Measuring the total weight of bloody material and subtracting the known weight of the same material when dry. So it is important that we know the baseline weight of the pad or of the drape that we are using. Actual blood loss may be far in excess of what is observed due to retained retroplacental, retrochorionic, or intraamniotic bleeding, or even a clot formation. So one very important message is please don't underestimate blood loss. Now, if the mother is unstable, in an unstable condition with a live baby, the first thing we need to do is send her to a tertiary care center. Do not manage it in a small setup because you are practically sitting on a volcano. Cesarean delivery is probably the best option when vaginal delivery is not imminent, and rapid control of bleeding is very much required because of maternal hemodynamic instability or significant coagulopathy. If the mother is unwilling to accept adequate blood replacement and therefore is likely to develop hemodynamic instability during labor. So correcting hypovolemia and coagulopathy by blood and blood products has to be a priority, and it should be done prior to or even during cesarean section. The C-section is generally performed under general anesthesia, and the presence of neonatologist is a must. If the mother is unstable and if the fetus is dead, what to do? So now here it is likely that the placental separation is often greater than 50%. So the optimal route of delivery in these cases minimizes the risk of maternal morbidity and mortality since the fetal well-being is no longer a factor. So we must replace blood and blood products and then expedite delivery. It is really important to do so because the frequency of coagulopathy and continuous heavy bleeding is much higher in abruptions in which the fetal death has occurred. Now, if the maternal condition is stable, but the fetal status is non-reassuring. So if it is a category 3 tracing, we must expedite delivery, usually by urgent cesarean section, and it is indicated if the fetal heart rate patterns suggest that there is an increased risk of fetal acidemia. So a biophysical profile score of up to 4 also suggests increased risk of fetal acidemia and needs expedite delivery. If the vaginal delivery is imminent, then a spontaneous or instrument-assisted vaginal birth is likely the least morbid route of delivery for this mother. For category 2 tracing, although a category 2 tracing may be managed by expectantly in patients without abruption, it is ominous in the setting of a probable abruption because it is a high risk situation for sudden fetal death or fetal deterioration. So delivery management will essentially depend on the gestational age, cervical dilatation, and whether there is a progressive deterioration in either the tracing or in the maternal condition. And depending on these two factors, we take a call as to what action or to be taken when we wish to deliver this mother. So close monitoring is essential and it is important. We should prepare for urgent delivery even in expectantly managed cases. Now, if the maternal condition is stable but the fetus is dead, the decision about delivery should be individualized, taking into account factors such as gestational age and cervical status. A previous classical hysterotomy is a relative contraindication for vaginal birth. Although these patients are at an increased risk of uterine rupture during labor, a 4 to 9% risk of rupture may be acceptable in the setting of fetal demise since C-section delivery has no fetal benefit. If the maternal condition is stable and the fetal status is reassuring, If the fetal heart pattern or biophysical profile is reassuring, then the decision to delivery vis-a-vis expectant management depends on gestational age and whether the abruption has led to onset of spontaneous labor. If the duration of pregnancy is less than 34 weeks, when the fetus and mother are both stable, there is no evidence of ongoing major blood loss or coagulopathy, we can think of doing a conservative management, especially to try and reach 34 weeks of gestation. For women who are in preterm labor in a stable condition, we should administer a 48-hour course of nifedipine. This allows us to administer corticosteroids, especially before the age of 34 weeks. Of course, it can be used even up to 36 weeks. Contractions by itself may be caused by direct or indirect effect of and may lead to further placental separation, which may in turn cause further bleeding, creating a cycle of bleeding and contractions. So magnesium sulfate for neuroprotection is important for pregnancies less than 32 weeks of gestation. What to do if the woman is not in labor? Now, women who are between, say, 23 to 34 weeks, we must administer corticosteroids to promote fetal lung maturation and reduce complications of prematurity. Antenatal fetal assessment should continue, especially at the later duration of pregnancy, where the non-stress test or biophysical profile can be performed at least weekly. Serial ultrasound estimation of fetal weight to assess the growth, since these fetuses are at high risk of developing growth restriction over time. There are a few questions that we need to keep in mind. If we want to hospitalize this patient, how long she needs to be hospitalized, because we don't want her to go back and have another episode of bleeding. At the same time, in private sector, there would be a cost involved if she requires prolonged hospitalization. A reasonable approach is to monitor the patient in the hospital for at least 48 hours. If the fetal heart tracings and ultrasound examinations are reassuring, and if the patient is asymptomatic. Patient should be counseled to return immediately if she has further bleeding, contractions, reduced fetal movements, or abdominal pain. And this has to be made very, very clear to her as well as to her relatives. In patients with sonographic evidence of large hematoma, it is prudent to keep the patient in the hospital for a longer duration of time because these women would require close monitoring. Now, when to deliver women with history of placental abruption? For patients managed conservatively and without any further symptoms, we must try and schedule delivery at 37 to 38 weeks, because if we decide to wait further, there would be an increased risk of stillbirth. Delivery before 37 weeks is indicated if there are additional complications like fetal growth restriction or preeclampsia or PROM or non-reassuring fetal assessment, or if the maternal condition is unstable. Placental abruption occurring in the second trimester carries especially poor prognosis, especially if it is accompanied by oligoamnios. Now coming to the management of abruption in 34 to 36 weeks of gestation. So here the delivery decisions are sometimes critical. Delivery may be worthwhile in patients with acute abruption at 34 to 36 weeks because these are the mothers who are likely to be compromised. The maternal health as well as the fetal health may be jeopardized if the placental separation progresses, and neonatal morbidity would be relatively low at this gestational age, and most of the NICUs would be able to manage these babies. Partial abruption can progress to total abruption suddenly, and that too without warning. So the fetus should be continuously monitored, and preparations must be made in case of urgent operative delivery is required. Management of abruption with more than 36 weeks to term. Now, preferably to deliver all pregnancies with suspected acute abruption at more than 36 weeks of gestation. So there is very limited role of conservative treatment in these women. This approach balances the relatively low neonatal morbidity of the near-term newborns in pregnancies with the risk of serious maternal and fetal morbidity and mortality if she progresses because of the abruption that is taking place, or if she lands up with recurrent episodes of abruption. Vaginal delivery, of course, is preferable if there are no obstetric indications for C-section. So we would reserve to perform a C-section if there are malpresentations or a prior C-section. With a clinically significant abruption, the patient is often contracting vigorously, but if she is not in active labor, then amniotomy and administration of oxytocin frequently results in rapid vaginal delivery. The care continues in the postpartum period. Of course, an intravenous oxytocin infusion is given as the first-line uterotonic agent. Maternal vital signs are monitored. We also must monitor the blood loss, urine output, uterine size and consistency, because we know that these women are likely to land up with postpartum hemorrhage. The laboratory tests which are to be performed would include hemoglobin or hematocrit and coagulation studies, and these have to be monitored very, very carefully, especially if the bleeding is ongoing. Women who developed shock and disseminated intravascular coagulation are at risk of multi-organ failures, especially acute renal insufficiency. So monitoring urine output is extremely important. And after delivery, organ functions usually improve with aggressive supportive care and treatment of complications as appropriate. It is important that we counsel the woman about future pregnancies, because there is a definite recurrence risk. There are a few studies which talk about a recurrence risk of about 3 to 15%, and that is pretty high. Placental abruption, preeclampsia, and growth restriction appear to be variable clinical manifestations of uteroplacental underperfusion, chronic hypoxia, and uteroplacental ischemia. So we have to ensure that we monitor these pregnancies very, very closely, and appropriate delivery interventions may be needed as per the situation. So to conclude, we must manage severe cases of abruption at the tertiary level center. Involving senior obstetrician and neonatologist is important. Please ensure that we keep adequate blood and blood products ready. Good laboratory facilities are important because we need to get repeated investigations done if the maternal condition is unstable. And of course, she would require all emergency care at all times. So we really need to be alert. So don't manage these women in small setup. Don't underestimate blood loss, because this is unfortunately we tend to do. And don't rush into delivering unstable patient, because you will do more harm than good. And don't miss out on small points in the history, because for the future conception and confinement, it is important that all our notes are properly written. So thank you very much. And once again, thank you, Sneha and Team AMOGS, for having me here.
Charu Madam and Ritu Sir for your...
I request Dr. Ritu Sir to kindly give his words.
It was a wonderful presentation, though I could hear maybe 3/4 of the presentation. But then, what I have to say is that this obstetrics is a bloody business. Bloody in the sense that lot of blood you have to encounter in your practice, like APS, PPH, ectopic pregnancy, a threatened abortion, and all those things. Okay. But how you manage is a tactfulness, as doctor has described in the case of APS, one of the APS, abruptio placenta, is present as well, lucid and very, what you say, elaborate, and then it was very educative. So I must thank him for the presentation.
Thank you.
I too would like to congratulate Dr. Parag Biniwale for that excellent talk, which he took us right through the definition to the risk factors. And I think just the fact that it's such an important cause of maternal and neonatal morbidity and mortality. And probably, we are heading, we are trying to reduce our maternal mortality grossly. So identifying factors and managing abruption is going to go a long way in reducing maternal and neonatal morbidity and mortality, and especially in cities like Pune, where we have good NICU setups. I'm sure we would like to err on the side of delivering the woman of abruption, essentially because, many of us must have had a slip between the cup and the lip because, we think that we have the situation under control. But as Dr. Biniwale rightly pointed out, that from partial abruption, it can proceed to complete abruption so rapidly that we may not get a chance to save the baby. And so maybe, we have to walk on the tightrope, make judicious decisions as to how to deliver and when to deliver the case of placental abruption. I think thank you also for mentioning about the predictive parameters about placental abruption, and also about quantifying the blood loss, and also for stressing on the need for general anesthesia in cases of placental abruption. So,
May I just also congratulate Parag? It was an
Thank you,
excellent
Murli.
talk. Yeah. And you have beautifully summarized it as do's and don'ts. And I tend to agree with you. At the same time, I also agree with Dr. Charlata that we always used to say in abruption, it is 3 A's. Number one is active management. There's no scope for conservative management at all, unlike in placenta previa. Second one is adequate blood transfusion, which you highlighted very nicely, and anticipate complications. And I used to jokingly teach, during undergraduates, if you err, then you will lose the baby first, then the mother, and then you lose yourself. How you lose yourself? Patient party will kill you. So, this is how I used to say. Excellent. So thankful to you.
Yeah, thanks, Murli.
Yeah, ma'am, over to you.
Yes, actually, everybody has said it all. So I think we should move ahead with the second talk. Hearty congratulations, Parag. Wonderful as always.
Thank you, ma'am. It was indeed an elaborate talk, sir. And we move forward to our next talk, which is by Dr. Sheila Mane, madam. Our chairpersons per session, Dr. Brajbala Tiwari, madam. She is the past president of the Indore OBGYN Society. She is the vice president of Indore Menopause Chapter, the past vice president of IMA Indore, secretary of the ISOPAV Chapter Indore, and the joint secretary and past secretary of various other organizations. We welcome you, ma'am, as the chairperson. Our next chairperson for today's session is Dr. Pranay Phukan, sir. He's a professor and head of the department at Tinsukia Medical College, Assam. He's a teacher of the undergraduate and postgraduate for the last 34 years, and the university examiner for all the undergraduate and postgraduate examinations. He is also an ICOG visiting professor for the year 2015-16. We welcome you, sir. Brajmala ma'am, I request you to please introduce Dr. Sheila Mane madam to proceed with the talk.
Thank you, Monica, for kind introduction. And thanks, Dr. Sneha madam, for including me in this important webinar. And it's my humble privilege to introduce none other than PPH lady we call Dr. Sheila Mane madam. She is currently DNB faculty at Bangalore, and she was the past vice president of Foxy, and she's the vice chairperson of ICOG. And madam had delivered so many keynote lectures, publications, and she is known worldwide as her PPH methods, and she is teaching everyone about the PPH, and she has so many accolades to her credit. So I welcome Sheila Mane madam for your talk on this PPH. Thank you, ma'am.
Thank you. Thank you. And for that kind introduction, and thank you, Sneha, for giving me this opportunity. It is nice to see our good friends, Bijwala is here, and so many from Northeast. Okay, Dr. Pranay Phukan. Okay, I still remember my visit to Dibrugarh, and I must tell you that it's nice to see that you are chairing this session, Rijmala and Dr. Pranay Bukan.
Yeah,
So
thank you.
I will go ahead with my presentation. Yeah, hello, Dr. Pranay.
Sneha ma'am, Dr. Hafizul sir has joined.
I think with Madam's permission, we just have Dr. Hafizul's few words. Yes.
Can you see my screen?
Yeah, Sheila Madam. With your permission, can we have
my screen is seen?
Yes, ma'am. Yes, ma'am. It's visible.
Screen is seen.
Okay. Yeah. Please. Yes. What do you want?
Dr. Hafizur.
Yes, ma'am.
Connor has just joined, so we just want to have his few words, madam. Yeah. So, Dr. Hafizur, welcome.
Please.
Yeah, ma'am. Good evening. Good evening, ma'am. I'm so.
Yeah.
Yeah, ma'am. I am so sorry. Actually, I was traveling. Sheila ma'am. Good evening, ma'am.
No worries. Welcome, Dr. Hafizur, and yes, we are eager to listen to you. Over to you.
Ma'am. Thank you so much, ma'am, for giving me this honor and opportunity. And as I would like to say, Sneha madam, we have been GC member, and Sheila ma'am, I am being knowing you for so many years. I would like to say, since I am a Foxy, I am entered in Foxy. Also, I know you. And thank you so much, AMOGS, all the office bearers and Sneha madam. But the topic which has been chosen, actually, the emergency obstetric care, it is definitely of the importance. Especially we have seen in our northeastern part, because there are some reasons still is there where we need to take care all the care of this. What is this? This is not only we have seen from the Western countries, but even I have had the opportunity to visit in our neighboring countries. There is one of the countries, that is Malaysia, where they have done so effectively, because I was a YZ and then I was for 2 weeks there, even in the rural areas. So the structured, organized emergency care has been a really important for the care of obstetric patients. Now that this has led to the maternal mortality in Malaysia even to lesser than even the UK, what is I have seen in 2017 and 18 in their data. My idea of pointing is that with such good care in the emergency, it is when we do the emergency obstetric care and along with the routine obstetric care, so this has the most impacts in taking care of maternal and child health. And definitely we have more importance in northeastern state, because still the maternal mortality has been so high. So with this, I would like to say this is going to be very much helpful to all the delegates and to us also. I am eagerly listening to you. Thank you so much, Sneha madam, and thank you so much. I wish you all the best. And I am being your support always, as well as Sheila ma'am. Thank you so much.
Thank you so much, Dr. Hafizur, for reaching here with so much of difficulties, and thank you so much for your precious words. Thank you so much. Over to you, Madam Sheila Mane. Please continue, and sorry for the interruption.
No. It was nice listening to Hafizur and knowing the Malaysia experience, because we have to really learn from each other. Thank you. So prevention and preparedness for PPH. I know now all of us have geared up so much, but still I think affects 5% of all birthing women, leading cause still, and you have a panel on near miss. So it is estimated that there are 10 near misses for every maternal deaths due to PPH, and that talks about the quality of care which give. So if you have more near misses, that means definitely it speaks about the quality of care in that facility. So improving clinical skills and knowledge of the risk factors of PPH are instrumental in preventing maternal morbidity and mortality. And all of us, we know the goal, that is by 2030, the global maternal mortality ratio should be less than 70 per 1 lakh live births. Now, there are some common preventable errors when we talk about prevention, but there are some errors. Dr. Parag also mentioned that under recognition of the blood loss, and I think we really missed the bus here. Then lack of appropriate attention to clinical signs of hemorrhage and associated hypovolemia. Then failure to act decisively with life-saving interventions and failure to restore the blood volume in a timely manner. So these are the common preventable, because all of this can be prevented. Now, I will not go into the details of definition. All of us, we know that primary PPH first 24 hours. The definition of PPH, vaginal delivery more than 500 ml, for cesarean more than 1000 ml. And PPH can be minor, 500 to 1000 ml, major more than 1000 ml. Major can be again moderate and severe, up to 2000 ml, 1000 to 2000, and more than 2000 ml is severe. So for clinical purposes, any blood loss that has the potential to produce the hemodynamic instability should be considered as PPH. For example, if you have an anemic patient, even if she bleeds 300 ml, she can have a signs of hypovolemia. Or a simple calculation is like this. A patient's weight multiplied by 100. Suppose she is 40 kgs, you multiply by 100. During pregnancy also, her blood volume is only 4 liters. So if she is going to lose 1000 ml, she has lost 1/4. She goes into class 3, class 4 hemorrhage. So depending on the hemodynamic condition, we will have to treat the patient. Now, massive obstetric hemorrhage is defined as a blood loss from the uterus or genital tract of more than 1500 ml at the rate of 150 ml per minute, or 50% of blood volume loss within 3 hours, or decrease in hemoglobin of more than 4 gram per deciliter, or acute loss requiring transfusions of more than 4 units of packed cells, or any hemorrhage associated with hemodynamic instability. All 4 T causes we know, atony being the commonest. Then these are the causes of PPH depending on the whether tone, trauma, tissue, or thrombin. Now, if we look at the tone, all of us, we know what are the risk factors. Trauma could be operative delivery, perineal lacerations, episiotomy also can cause. Tissue, retained placenta or adherent placenta, which is our nightmare nowadays. And thrombin could be in cases of preeclampsia, HELLP syndrome, bleeding disorder, sepsis, or sometimes it could be drug-induced. So there are 3 broad areas in which the outcome of PPH may be improved. So that is, one is prevention, then comes the treatment, and then comes the rescue. So prevention covers antenatal strategies, active management of 3rd stage of labor, and treatment for retained placenta. And PPH treatment covers both medical and surgical. And rescue therapies include IV fluids, blood transfusion, coagulation correction, supportive care such as compression garment, or it could be even the balloon tamponade. So this is the histogram of blood loss at delivery showing the death zone at a loss of over 40,000 of blood volume, 40% of blood volume, and the 3 strategies for intervention. So prevention first. We have diagnosed, then the treatment, and then the rescue. So at all these stages, we can save the patient from dying due to PPH. Now, if we have to talk about prediction and antenatal risk factors, because when we talk of prevention, if there is a previous history of PPH or retained placenta, maternal anemia, maternal age, 35 years or more, body mass index more than 35 kg per meter square, grand multis, antepartum hemorrhage, over distension of uterus, and pre-existing uterine anomalies. So antenatal history, we should know this. There are risk factors in labor too. Induction of labor, prolonged 1st, 2nd, or 3rd stage of labor, secondary arrest of labor, especially in multigravidas, use of oxytocin, precipitate labor, operative delivery, or cesarean section. So prevention, a patient safety bundle is a set of straightforward evidence-based recommendations for practice and care processes known to improve the outcome. And the consensus bundle on obstetric hemorrhage is organized into 4 action domains. That is, readiness is the key, recognition and prevention, response and reporting, and system learning. So there are 13 key elements within these 4 action domains, which if we have done properly, we can definitely save the patient. Readiness, all of us, we know everybody should have a hemorrhage cart with supply, checklist, instruction cards for even intro and balloon and compression stitches, immediate access to hemorrhage medications, establish a response team, that who to call when help is needed. For example, the blood bank, you need an advanced gynecological surgery, so you need a vascular surgeon or oncosurgeon, other support and tertiary services, establish massive and emergency release transfusion protocols. When we say massive transfusion protocol, we should have a MOU with the blood banks that in case of an emergency, when the patient is unconscious or you need immediate blood, there is no need to cross-match. They should release type O negative blood or uncross-match group-specific blood. They will not do if you don't have a MOU and you will waste time. So you have to talk to your blood banks. Unit education on protocols and unit-based drills with post-drills debrief so that you know that what went wrong and what went right. Recognition, assessment of hemorrhage risk. We just saw prenatal on admission, measurement of accumulative blood loss, formal and as quantitative, and active management of third stage of labor. Response, every hemorrhage, unit standard, stage-based obstetric hemorrhage plan with checklist and support program for patients, families, and staff. Reporting, a culture of hurdles for high patients and post-event briefs. Review of serious hemorrhages for system issues and monitor outcomes and process metrics in perinatal quality improvement. So these are very important. Debriefing after AIDS. So readiness, yes, there are 5 areas of focus to be addressed by every facility to prevent delays and prepare for the optimal management of obstetric hemorrhage. Readiness aims at improving interdepartmental coordination. So all of us, we know about the CART. We should have all the oxytocin, and another drug which is added to this is now carbetocin as well as tranexamic. So it should be ready to rule out the trauma. So vaginal retractors, speculums, long instruments, your sponge holders, intrauterine balloon also should be kept ready. Banjo curate, bright task light, and procedural instructions also. Some junior is doing a cesarean, he wants to know how to put B-linch, it should be there. And operation OT theater should be ready with all the trays where a cesarean and laparotomy is done. Now, if you have to establish a response team, determine who will be the part of your core response team. So primary maternity care provider and nurse, clinicians from anesthesiology, transfusion service, pharmacy, advanced gynecological surgery, critical care medicine, because you may require HDU, ICU, main operating room, interventional radiology, and additional nursing resources. And use readily available phone or pager numbers or a rapid response or a code system. I sometimes I feel that we should have a H code for hemorrhage. So a code system should be there for an emergency. Establish massive and emergency release transfusion protocols. Okay. So you have to prevent dilutional coagulopathy because that can result if a significant percentage of the patient's blood volume is replaced with large quantities of crystallite, colloids, or only RBCs. So as volume is replaced, attention must be paid to coagulation parameters, platelet count, and metabolic status. So prepare and prevent hemorrhage. So that is, you will have to have these basic investigations. All of us, we know about AMTSL, and we know uterine blood flow is almost 700 to 800 ml per minute during pregnancy. So the uterus can simply pour and lead to death within minutes. And these patients matter low BMI, anemia, and preeclampsia as they have a shrunken intravascular compartment. So when you are managing PPH, you don't call for help, you shout for help. You resuscitate all at once with IV fluids, oxygen, arrest the bleeding. Either you are doing massage or bimanual compression or aortic compression, but arrest the bleeding. Communication is very important because even though it is a non-clinical part, plays a very important role with staff, with patient and family, identify cause of bleeding. You must have a gray color cannula in PPH kit because you can transfuse the fluid at the rate of 180 ml per minute. The difference between different cannula and 180. Your patient is bleeding, you will have to replace the volume in the ratio of 1:3. 1000 ml blood loss up to 3000, till then the blood arrives. So ABC, large bore IV access, IV set, blood 6 to 8 liters, infuse crystallite immediately blood. Okay, and you giving oxytocin. Medications, all of us we know. Oxytocin 10 units IM or 5 units IV bolus or 20 units in 500 ml infusion. Carbo you can give if no contraindication. Methyl ergometrin also can be given 0.2 milligram IV or IM, and misoprostol 800 microgram rectally. You have to identify the cause and treat accordingly. So all of us, we know oxytocin acts faster, misoprostol takes time, so it is not a first-line drug. Ergometrin sometimes is useful in the lower segment bleeding if there is no control. And of course, carboprost also can be given in 8 total dosages. You can give is 250 microgram intramuscularly every 15 minutes, up to 8 dosages. Even you can give it myometrial if there is no contraindication. So all of us know about the women trial and the role of tranexamic acid. There should not be any delay in giving tranexamic acid once we have diagnosed postpartum hemorrhage. Even it can be given. And all of us, we know that very soon we will be hearing about Women 2 trial, where in anemic patient also you can give it as a prophylaxis along with oxytocin. Even you can give 500 milligram intramuscular also, because in anemic patient, the clot dissolves early. So if you give tranexamic, it will definitely help to reduce. Now, there are so many newer drugs in armamentarium like recombinant activator factor 7 and even fibrinogen. Okay. Now, if you have to give factor 7, you have to have the fibrinogen level at least 1.5 to 2 gram per deciliter. In that case, if the fibrinogen is low, level is low, factor 7 will not act. So correct it either with cryo, FFPs, or you can give even fibrinogen, which is available now. Okay, so that is there. Carbetocin, all of you know, the Champion trial, heat stable carbetocin is not inferior to oxytocin, and this was the trial which was conducted by India, and it can be used for active management of third stage of labor. So now it is developed for hemophilia, but now there are papers coming out for its uses for PPH, because it acts according to the extrinsic pathway and it controls the bleeding. So if there is a facility available, it also reduce the number of transfusions. So the patient general condition will tell you whether the patient needs blood. Okay, tachycardia, immediately transfuse to PRBCs and then order for cross match for further units and consider giving FFP. Hypotension, you will have to activate massive transfusion protocol. Now, aortic compression, most of the time, you know, I said that you have to arrest the bleeding. Okay, aortic compression does not prevent or delay any of the other steps. You will have to do that. But circulating blood volume is restricted to the upper part of the body. Blood pressure is kept higher. Blood is prevented from bleeding area. Qualified person at hand may have to carry out the compression to stop massive bleeding. And this technique is assigned to a helper so that most qualified person is not tied up. And blood is conserved by cutting. Now, if you have done a cesarean and you want to control, we can directly take a wet mop and directly put it on the aorta and control the bleeding by doing aortic compression. Okay, I will not go into the details because I have to talk about other things, but you will have to explain the patient. And once you go slightly above the umbilicus towards the left side, feel for the femoral. It should not be felt. Otherwise, you'll have to go on compressing more. Don't worry. You have to compress. You can do it for 10 minutes or 15 minutes also. Doesn't matter. Okay. Carbetocin, a newer long-acting analog. Okay. After IV injection, it produces sustained uterine contractions within 2 minutes, lasting for 6 minutes, followed by rhythmic 60 minutes. So it has a action which lasts for longer time, and if it is given by IM, the sustained uterine contraction lasts for 11 minutes and rhythmic for 120 minutes. Okay, so heat stable carbetocin was found to be stable at 30 degrees centigrade for 3 years. So we are using it now. I will not go into the details. All of us, we know about it now. So hemorrhage drill. Now, what is hemorrhage drill? A drill refers to a clear and logical set of steps involved in patient's management. All team members are familiarized with the entire safety bundle and new management plan. Participating members are assigned tasks and responsibilities necessary to run the drills, and post-drill debriefing provides an invaluable opportunity to learn from the experience, sorry, to reinforce areas of the drill that went well, discuss areas in the need of improvement, share lessons learned, and highlight the system issues to allow for concrete planning for potential solutions. And it may be combined with practicing infrequently used hemorrhage technical skills like a tamponade, balloon tamponade, and compression sutures. Coming to now recognition and prevention. Assessment of hemorrhage risk. Identification of risk helps to improve the readiness allows increased surveillance and early recognition, and the use of preventive measures, and it prepares the team to initiate an early, aggressive response to bleeding. So it should be considered multiple times. We have assessed antenatally, then you again assess it during labor and late in labor. Okay, we have to assess all these parameters. Rule of 30 also can be used, where the fall of blood pressure systolic 30 millimeters, heart rate is increased by 30, hematocrit is decreased by 30. In those cases, the patient has already lost 30% of blood volume. That means it is a class 3 hemorrhage, and patient will need multiple transfusions of all the blood products. Shock index is 0.7 to 0.9. That is pulse rate divided by systolic blood pressure. Okay, if it goes beyond 9, that means your patient is in hypovolemia and you will have to immediately start. Okay, more than 1, your patient is in shock. Assessment of stages of shock, again depending on the blood loss. If you look at this table, you will see that in group class 1 and class 2, still the parameters are not altered so much. So shock index in these cases will definitely help you to diagnose the blood loss early. Okay, in class 3 and class 4, you will find that the patient has tachycardia, hypotension, and all that. Okay, so risk assessment, prenatal we saw. On admission, again medium and high. On admission, you check whether there is cesarean history, uterine surgery, multiple laparotomies, multiple gestation, multigravida, prior history of obstetric hemorrhage, large myoma, large baby, obesity, and patient is anemic. These are medium risk. High risk are placenta previa, low lying, suspected adherent placenta, platelet count less than 70,000, active bleeding, known coagulopathy, or if you have 2 or more medium risk factor, it becomes a high risk. Intrapartum, now these are, you have assessed antenatally. Intrapartum chorioamnionitis, prolonged oxytocin for more than 24 hours, prolonged second stage, if you use magnesium sulfate. High risk, new active bleeding, or 2 or more medium risk factors, okay, on admission and or intrapartum. So your assessment will continue. Then measurement of loss is very important. So estimation of blood loss, a glance and guess is a common practice where we will underestimate. So direct measurement can be accomplished by 2 complementary approaches. Easiest way, collect the blood in calibrated underbuttock drips, okay, for vaginal birth, or and second approach is blood soak item clot and weight of the subtract the total to obtain an estimate of blood. And you have labor, you know, that even a smaller swab, 10 into 10 centimeters completely soaked, is 60 ml. Medium is 140. Okay, like that, if you have a chart already put up in your labor room and you are using the same thing, you know the dry weight, and then you will have to subtract, okay, the dry weight. So that will get and WHO has already recommended that. So we do that. Coming to the response. Response means every hemorrhage. Obstetric hemorrhage emergency management plan is a critical step in to determine the etiology. Stage-based management plans have been found to facilitate an organized stepwise response to blood loss and maternal warning signs. And they ensure that the resources are not wasted while each patient receives optimal therapy. And each institution needs to adjust the plan to meet its individual capabilities. So you have class stage 0, where you assess the risk factor, you do the active management, and if the patient is high risk, you have already cross-matched and kept to blood ready. If it is class 1, where the estimated blood loss is either more than 500, more than 1000 in cesarean, then you start a big or cannulas, you start the IV fluid, you put a catheter, you do massage, and you consider additional uterotonics, but you keep 2 cross-matched PRBCs ready. Stage 2, patient continues to bleed. She bleeds with estimated blood loss, it's still less than 1500 ml. You will have to send all the investigations, including the coagulation profile. You may have to think, if the medical management fails, whether you will have to take her for emergency laparotomy. You can PPH methods like intrauterine balloon, or if you have the family, select embolization. And in cesarean, if you find patient is, you may have to insert ligament also. Okay. You can put a suture or a modified BL, and if you further care up to see if it is not, you may have to go for ligation of, okay, and consider definitely transfusions, and you may have to give FFP, platelets, and again you will have to give her additional. So depending on the blood loss, you will have to replace the blood and blood products. And massive transfusion protocol, you just order 1:1:1 with all other measures, whatever you are doing. But if the patient is hypotensive, first stabilize the patient. You ask for massive transfusion protocol, you stabilize the patient, immediately shift the patient to OT, and then if she requires surgery, you may have to take her. Or if she has delivered vaginally, there is a DIC, you may have to give her massive transfusion. So you first order 666. By that time, you will get your coagulation profile. If your patient has still not improved, she still continues to bleed, you will do other measures. You will ask for another round of 666. Sometimes in situations, we have give 70 to 80 transfusions. You don't have to stop, okay? And in these situations, you can use fibrinogen, you can use factor 7, all those things, okay? Now, once you diagnose PPH along with oxytocin, don't forget to give tranexamic acid. Support program. For patients' families, women and their families need timely information, reassurance, and opportunity to discuss the incident and maternity care. Reporting and system learning. Establish a culture of hurdles and debriefs need to be routine, multidisciplinary review of serious hemorrhages, and monitor the outcome and the process metrics, which we should start doing. Then only our system will improve. Now we know that as we are talking, that the blood loss estimation is an error. At the beginning only I told. So the WHO has come out with a newer study now, that is E-motive. What is E-motive is, M is for massage, O is for oxytocin, T is for tranexamic, IV is for IV fluids, and E is you escalate. That means you have done all this till the patient is bleeding, you escalate. So you treat refractory PPH, you apply anti-shock garment, you arrange flawed blood, you apply tamponade. Still not working, escalate to surgery. So because E-motive study was done, because they came to know that in spite of diagnosing PPH, the resuscitation is delayed. So there comes E-motive. And there are different technical skills improving clinical knowledges. I have attended this prompt, okay, and we have training people also, and I do these drills regularly, and that will definitely help. Then obstetric emergency simulation training will also help, and non-technical skills like communication, teamwork, and leadership. Because once there is a problem, you have to have a helicopter view of the situation and then give the instructions, and your communication should be clear and louder so that there is no chaos in type of an emergency. So the patient is in the center, maternal safety is important, maternal satisfaction is important, and also the family support. So what you need? You need knowledge and experience plus expertise. Situational awareness is very important. Communication skills and understanding of team members. Multidisciplinary team, where you have to know that whom all you require from your lab, your blood bank. You may need a senior surgeon or oncosurgeon or vascular surgeon. So appropriate team members, closed loop communication, okay, and flattening of hierarchy. Infrastructure, your blood bank, robust blood bank, your auxiliary staff, access to equipment, local guidance, and emergency boxes should be kept ready. Simulation training, if we have done the debriefing, we know that we have to teach the technical and non-technical skills, improved communications, team working, and knowledge of local protocols. And assessment, I have already told, which we have to do antenatal as well as. Okay. So, dear friends, I think still postpartum hemorrhage is a problem for all of us. And we have to see that the patient is not anemic when she enters the labor room, because that will definitely help us to prevent so many problems. Because the anemic patient bleeds more, there are 5 reasons. One is her heart rate is more, stroke volume is more, she bleeds more. Second, the viscosity of the blood is more as the RBCs are less. Third, that there is the lamellar flow in the blood vessel is lost. So the platelets are not at the periphery to clog the capillaries. Fourth, there is early the fibrinolysis. That means the clot is dissolved early, and iron deficiency makes even the myometrium weaker. So it's very important that we treat anemia antenatally so that, many problems can be avoided. So thank you for your patient hearing, and I think I can stop here and then take questions.
Thank you, Sheila ma'am. So nicely, in a very short period, you have covered almost all new things. It's very practical things. Some, of course, our clinical practice still being the highest maternal mortality in Northeast, and one of the important causes of maternal mortality is postpartum hemorrhage. It has been observed that patients who are carefully taken care during the antenatal period, normally we can get rid of those complications. But in government hospitals, probably the mortality is high because of all the things that we have discussed. We should be very careful about taking care of the patients, starting from the antenatal period, correcting her anemia, and especially, as you have rightly said, that we should have a good team in the institute. With the blood bank officer is very, very important. Not to speak about the other faculty, it's a very important person there. And then he or she should be included in that particular team so that we can get the blood. And then newer some other things like new concept of permissive hypotensive resuscitation. And that is a procedure by which you can keep the patient mean arterial pressure in between 55 to 65 till the patient is bleeding. And then once bleeding is stopped, it can be corrected. That is a new recommendation price given. Probably,
bleeding of adherent placenta or placenta previa. That is the newer thing. So that, the patient does not bleed more. Yeah.
Again, the placenta lacuta syndrome, that triple P procedure is very essential for, especially the surgeons. By triple P, probably we all know. First of all, we have to localize the placenta, where exactly it is antenatally. Secondly, we can just we devascularize the placenta, uterus. And thirdly, we can just remove that part which is attached where the placenta is adhered, and the rest we can just repair like myomectomy we do. So definitely these procedures are very important at present as we're getting more and more patients of PAS. Those so many things are to be discussed.
Placenta, yes.
Yeah. So
very right. I would like to know, is it a problem for you in Northeast also, adherent placenta? Hello? Adherent placenta.
Is the incidence rising? Are you meeting such cases quite frequently? That is what Madam wants to ask.
I think
he lost the connection.
I think sir lost connection. Thank you so much, Sheila Madam. It was very, very elaborative talk. And rightly said by you that we have to keep the team ready, and PPH training to our staff is very important, and anti-shock garment should be in our labor room. So that is very, very important. Thank you so much, ma'am.
I think Dr. Pranay Pukan, I wanted to ask him, in fact, in Northeast, they have so much of problem till the patient is shifted or transferred. And because last time when I did one or few webinars for the Northeast people, they did not have that. And in fact, I think it is must there, because when they have to shift the patient from hilly areas where they don't get the blood. Okay. And one other problem Dr. Pranay Pukan has lost, their problem is hypertension in Dibrugarh, because they have these and all these laborers who work there, you won't know, most of them are hypertensive, the young patients also, and they come with eclampsia. That is their problem. And why they think they're working in the fields and they're sweating and they add salt to their tea, so the salt consumption is very high in them, and the incidence of hypertension is very high in Northeast. So
exactly,
eclampsia are more prone to develop complications also.
I can see Dr. Pranay joining.
Dr. Pranay Pukan, can you?
I was disconnected. So thank you very much. Probably we should stop it here because other sessions are still waiting. It's a very beautiful discussion.
So one thing I wanted to add, last time I learned from you that in your area, preeclampsia and eclampsia is a very big problem.
Yes.
Because hypertension is very common, the T laborer.
Yes, ma'am.
No? So that is also can cause. And I wanted to know whether your incidence of adherent placenta is high now in Northeast?
Yes, ma'am. It is a dreaded condition now. We are getting initially tell the truth, we have lost few patients. After that, we are discussing amongst ourselves and the faculty members, and we are very careful to save the patient nowadays. So the patient,
you have anti-shock garment?
Pardon?
Do you have anti-shock garment in all the facilities?
Yes, we have the anti-shock garments, but yet it is used. Yeah, sometimes still the patient is shifted to the operation theater. Yeah, we have it there.
Yes.
Okay,
so thank you so much,
Nice to
Sheila
know that.
Mane, for your elaborate talk, and thank you so much, Dr. Pranay Fukon, for your very interesting discussion on this topic. Thank you so much. Thank you so much for chairing this session also.
Thank you.
Thank you.
Thank you,
Sneha, and wish you all the best. He's a great obstetrician. Obstetrician is very obstetrics is very close to her heart, and she will always choose such topics that which will be helpful for the society and for the practicing clinicians. Thank you for the invitation and all further program of panel discussion on ERMs. Thank you.
Thank you so much, madam. Thank you so much for your kind words, and thank you so much for all of your support all the time. Thank you so much.
Thank you. Thank you, Sheila ma'am. Thank you, Brajbala madam and Pranay sir for chairing this session. Ma'am, I would also like to highlight that there is a very high incidence of gestational trophoblastic disease in the Northeast as well, ma'am. Hello, am I audible, ma'am?
Yes, you are, Monica.
You are audible. I would like ma'am's connection is.
Yes. I would like to now hand over the session to Dr. Shatabdi Dey to please carry forward the panel discussion. Shatabdi, over to you.
Yeah, thank you, Monica. I'm sorry, some electricity issues over here, so I might not be seen. That was a really two very enriching lectures by Sheila Mane madam and by Parag sir. Now we are looking forward to a very interesting hour of discussion on near missed case scenarios in obstetrics. A very important thing which we encounter in our day-to-day practice, various near missed cases, and which we really have to take care if we have to control the mortality rates in our country. So we have two expert moderators with us, very dynamic Sneha Bhuyar ma'am and Dr. Priyankur. Now, Sneha Bhuyar ma'am is one of the senior gynecologists of our country. She has been the president and secretaries of various committees, AMOGS chairperson of the Medical Disorders Committee, currently the Emergency Obstetric.
Thank you, Shatabdi. You can go ahead. I have been introduced.
Yes, ma'am. Thank you, ma'am. Welcome, ma'am. Our second moderator is Dr. Priyankur Roy. Dr. Priyankur is an associate professor at Lord Buddha Koshi Medical College and Hospital at Saharsa. Consultant gynecologist, infertility and gynae endoscopy specialist at Roy's Clinic at Siliguri. He has very many awards to his credit, and he has presented.
Shatabdi will do. Thank you.
Yeah, thank you. Welcome, Priyankur. We have two experts for the session. Our first expert for the day is Dr. Apurva Kumar Bhattacharya, sir. Sir is the professor and HOD in the Department of OBGY at Nalbari Medical College. Thank you for accepting our invitation, sir. He's a senior vice president of IMA Assam State Branch, as well as the president of SFM Northeast Chapter. He's associated with various organizations. Welcome, sir. Our next expert is Dr. Kavita Mandrel Bhatti, ma'am. Ma'am is the professor and head at CMC Ludhiana, also the vice president of the Ludhiana Obs-Gynae Society and the president of the Ludhiana Menopause Society. She has various publications and awards to her credit. Welcome, Kavita, ma'am. We have 7 dynamic panelists with us. Our first panelist is Dr. Kirtan Vyas. Dr. Kirtan is a consultant director at Sevak Maternity and Surgical Hospital, Ahmedabad. He has a teaching experience as an assistant professor and the recipient of various awards and appreciations from Gujarat University and from Foxy. Welcome, Dr. Kirtan. Our next panelist is Dr. Indrani Roy, ma'am. Ma'am is a senior consultant and HOD in the Department of Obstetrics and Gynecology at Nazareth Hospital, Shillong. She has been the president of the Shillong Obs-Gynae Society as well as the organizing chairperson of the East Zone Yuva Foxy. Welcome, Indrani, ma'am. Our next chairperson is Dr. Sindhu Bala, ma'am. Ma'am is a senior gynecologist and consultant infertility specialist at Siliguri. She is a clinical director of Creation the Fertility Center and consultant at Arogya Niketan Hospital. Welcome, ma'am. Our next panelist is Dr. Ejaz Hussain, sir. Sir is a senior gynecologist at Tata Referral Hospital, Chabua. He also is the senior vice president of Dibrugarh Obs-Gynae Society and the facilitator of the cancer screening program of ICMR. Welcome, sir.
Thank you.
Our next panelist is Dr. Pulak Kalita, sir. Sir is an assistant professor in the Department of Obs-Gynae at Assam Medical College and Hospital at Dibrugarh. He is an active member of FOXY, IMA, ISOPAB, etc. And he has various publications to his credit. Welcome, Dr. Pulak, sir. Our next panelist is Dr. Pratibha Pasari Agarwal, ma'am. Ma'am is an IVF specialist at Apollo Fertility Hospital, Apollo Fertility at Guwahati. She is also the secretary of the ISOPAB Assam chapter and the executive member of Guwahati Obs-Gynae Society. Welcome, Pratibha, ma'am. Last but not the least, we have Dr. Jayashree Goswami, ma'am. She is an assistant professor in the Department of Obs-Gynae in Guwahati Medical College and Hospital. Welcome, Jayashree, ma'am. Over to you, Sneha, ma'am, and Priyankur for further discussion.
Yes, thank you so much, Satabdi, for that kind introduction. And I welcome my dear friend, Dr. Priyankur, as my co-moderator. And I welcome all the panelists. They have been introduced already. So I hope my screen is visible. I think
ma'am, it's visible,
except Dr. Kevin, we have all the panelists here. I'm very happy. Thank you so much, everyone, for joining. And without much ado, I think we start with our discussion. So friends, our discussion today is on near miss, the case scenarios. So near miss, this terminology we have borrowed from the airlines industry. It tells you the gravity of the situation and the urgency of demand, it is required. It tells you that, this is about a pregnant lady. I think slightly we need to mute the rest of the people, the rest of the members. So this is about the critically ill pregnant woman or the recently delivered woman who would have otherwise died had it not been the luck or a good care on her side. So we really have to discuss such cases and we have to analyze. Definitely, there is a scope for improvement. This we have to do because WHO itself says that there is nearly more than 10% of the near miss cases, or the maternal mortality from India that could have been saved. So, friends, maternal mortality rates, it's not only the rates and ratios and numbers and figures. These are women. They have their own faces, and we obstetricians have to see these faces in the face of their agony, distress, and despair. So these continue to haunt our dreams. That is how it has been expressed by Mohammad Fatala. And similarly, the Ian Donald also has expresses, that over the time of clinical periods, one tend to forget the failures. And it's only the success which is taken for granted. But these are the failures which stand out like keloids. And it is, the reminder for the person who has faced it, and of course, the warning for others. So friends, I'm sure every case is different and every time you get to learn something different. So never stop learning because life never stops us teaching. So with this, I think Priyankur, would you like to start the first case? Please go ahead. Hello. Yeah, Priyankur, do you want to start the first case?
Yeah, ma'am, I don't mind. Thank you so much, Sneha ma'am, for this excellent session. And first of all, I would like to congratulate you for conducting this webinar, which is a very neat of the hour, I would say. And I would really, it's an earnest request, which we often don't do, but then on a scientific platform. But then Sneha ma'am has been one who has taken up academics quite very sincerely and has been on the platform and has been in the whole scenario for a very, very long time. She has been a very active chairperson of the breast committee and done very, very well. So she definitely, I am sure she definitely deserves to be vice president of FOXY. And I think I wish you all the very best, ma'am. And I'm sure you will get the support and blessings of everyone as well. So, all the best, ma'am. Yeah. So, ma'am, taking the first case first, we have a second gravida who's been a previous cesarean section. Last childbirth was 1.5 years back. She comes with 7 days overdue. So this is one of the things. It already says that the UPT is positive. But if I could ask, we have Kavita Bhatti ma'am with us over here. Kavita ma'am, if I can just put the first question to you, if I can just ask you once, UPT 7 days overdue, we will definitely do a UPT, but this is mainly for the postgraduates and all who are present over here. Even if the cycles has not been very, very regular, has been little irregular, shortened cycle, do you think that UPT is something that should be done? Because it is something that we definitely need to rule out, and especially in cases of lactational amenorrhea, do you think it's very, very significant?
Do we
Kavita
have
ma'am, can I request you to unmute yourself?
Yeah, Dr. Priyankur, I'm not the panelist, but definitely
I know, ma'am. Ma'am, this was just because I wanted an expert opinion from you for this. I know you are the expert
Can
over
I
here,
get
ma'am.
the
Just
question
expert
again,
opinion.
please?
Yeah, I just wanted to know the significance of urine pregnancy test, not only in overdue cases, but also in cases where probably, it's a shortened duration of cycle, and also in cases during the lactational amenorrhea when they have bled once and then stop bleeding.
Yeah,
Just wanted your
surely,
opinion
because
regarding the same.
whenever a patient who's in the reproductive age group, the first and foremost diagnosis when the patient comes with missed periods will obviously be a pregnancy, and we have to rule out by doing a urine pregnancy test. And moreover, especially when you say it is lactational amenorrhea, then that time she may be ovulating without having periods. So it is actually indicated during that time also if they present to us with amenorrhea.
Absolutely, ma'am. I think the point very well taken, and I
Actually,
think
we always tell our
especially
residents whenever a patient comes in the reproductive age group in the casualty with amenorrhea, you have to do a pregnancy test. That is the first thing that we do.
Absolutely. And we have so many professors and HODs over here, and I'm sure this is one of the statements that we give to most of our students. Please do a urine pregnancy test wherever you feel, especially in the lactational amenorrhea period, in the perimenopausal age group, where we think that pregnancy cannot happen. But always remember, it's unlikely, but definitely can happen and definitely needs to be ruled out. Going
Correct.
forward
Moreover,
in this case, of course.
yes, Priyankur.
Yes, sir.
Moreover, I
Yes,
would
sir.
like to add,
Please, sir.
As Kavita madam has rightly mentioned, that urine pregnancy test is a very simple and effective test that it can even be performed with a paramedic, and it can just give you a glimpse of the situation, that yes, whether the entire management part would differ, whether the patient is pregnant in the clinical scenarios, and when the UPT is negative, when the patient is not pregnant. So it's I believe it's one of the first step for examination in such patients, as Kavita madam has rightly mentioned. Yes.
Absolutely, Dr. Kirtan. Again, point well taken. So to take this
Even
forward
nowadays,
now, both of them have suggested. Sir, please go on, sir.
Even nowadays, patient comes with a urine pregnancy test, doing at home only because the kit is available, easily available at the pharmacy.
So freely and available, very exactly.
They do come
Exactly,
with.
sir. Only thing is to raise the awareness the times when they have to do it. Probably that is something that we also need to little stress upon when they come to us, especially when we discharge a patient post delivery and post cesarean section. They're going home lactational amenorrhea. They come for a checkup, to stress on the fact that if you have one cycle and then probably continue missing a cycle, do a UPT and come back, because that is a gray zone that the patient do not sometimes test. Very well said, sir. Thank you so much. So now everyone had suggested a pregnancy test and it came out to be positive. So now she wants a medical abortion. Doctor prescribed it and called for follow-up after 7 days. She had spotting only and giddiness and on and off pain in the abdomen. On 6th day at 11 p.m., she collapses at home, and she is brought to the hospital by her relatives. Next slide, ma'am. So now can I go to Dr. Indrani, ma'am? Ma'am, you're with us. So welcome, ma'am. Or we can even take this question with Dr. Kirtan. Kirtan,
Yes.
this patient has been brought to the hospital with a pulse of 132, blood pressure of 70 mm of Hg, Pelaris plus plus. So what is the differential diagnosis?
Okay. So first of all, as it has already been mentioned, that her UPT is positive, and our age-old dictum says that be ectopic minded. When the urine pregnancy test is positive, patient is in a collapsing state, the first ever diagnosis without thinking anything we should put is an ectopic pregnancy, or a ruptured ectopic pregnancy to be precise, right? So whenever patient arrives to you, the first and foremost thing, of course, in such a patient, to resuscitate it, okay, we have the record of her urine pregnancy test being positive. So of course, be ectopic minded, and as soon as she settles down, her clinical examination, right from per abdomen examination, whether any abdominal gross evident abdominal distension is present or not, any tenderness guarding rigidity is present or not, to rule out any intraperitoneal hemorrhage, to be precise. Her per vaginal examination also to rule out any fornicil tenderness, to know the site and size of an ectopic pregnancy, and of course her immediate bedside blood test, including hemoglobin, and to be precise, CBC would be a better choice. But yes, the first and foremost would be to assess the amount of blood loss, and hemoglobin is a immediate marker. And as soon as she is stable a little, we can go ahead with the ultrasonographic assessment to confirm our diagnosis. If we don't think if
Perfect,
the
Kirtan.
ectopic pregnancy is ruled out, even in some cases, a large corpus luteal cyst may even present with a similar finding, a rupture of a corpus luteal cyst, or even a torsion of an ovarian cyst may even present. But most of the times, hemoperitoneum and pain in abdomen with urine pregnancy test positive will indicate to be it a ectopic pregnancy, a rupture of ectopic pregnancy.
Yes,
Perfect, Kirtan. I think so. The point.
Kirtan, very well discussed. In fact, only one point I would differ from you, Kirtan, that you don't wait for the stabilization of the patient because she is bleeding inside. So the amount of whatever fluids you infuse, you at the moment you diagnose and suspect, even you send her lab for investigations, arrange blood and blood product, and you try to resuscitate and arrange for the operative procedure. So
yes.
perfect.
Correct.
Otherwise,
So parallel teamwork would be of help in such a case.
Absolutely. I think it has to be multiple partners or multiple caregivers who have to be involved in the case. And only one point that I would like to urge all of you who are present over here: please do not do a medical termination of pregnancy without doing an ultrasound. Understand one thing: after you have given even an MTP and you have not done ultrasound,
we can label this at one of the first near miss scenario, that the MTP pills had been prescribed without sonography, as it has not been mentioned. So we presume that it was prescribed maybe by a general practitioner or whatever it is, without confirming the site and size of pregnancy.
Yeah,
But
in fact,
so I think
learning lessons. Yes,
but
Doctor.
it should be
Yes, sir. Please.
It should be case specific, because ultrasound is not a mandatory for prior to MTP. But since it's a case of post CS, so ultrasound should have been done earlier. But otherwise, I don't think for every MTP cases ultrasound is a mandatory requirement.
Actually, we should. You are right in a way that ultrasound for every pregnant woman is not mandatory before termination of pregnancy by law.
But it's a post CS case.
By law, it is not mandatory, but it is recommended that all of you do this, because if it is ectopic pregnancy, the rupture, it becomes a dreaded complication.
Yes.
So it is recommended, not mandatory. So for the
yes, sir. So I think
we should go for it.
Yes, I think so. Same thing as yes, ma'am. Kavita, just one thing, ma'am, just to reiterate. Yes, ma'am. Please tell us, ma'am. Please tell us.
Sorry, because the ultrasound is not needed for diagnosis of ruptured ectopic pregnancy. It is a clinical diagnosis. If you see the patient is actually giving history of UPT positive and she has fallen down, she had syncope, all the features of shock are there. And obviously she must be having hemoperitoneum with abdomen distended. So
yes,
ma'am, not a diagnosis of rupture.
We are not discussing ultrasound for diagnosis of rupture ectopic.
I
are talking about before prescribing the
intrauterine.
Yeah, I know that, but because it was mentioned that ultrasound should be done for the diagnosis.
In fact, that is what I said. Don't wait for any investigation. Don't wait for even the patient to get stabilized and go for operative intervention.
That is what I wanted.
Yes, ma'am. So basically, I think we have examples even in here in Siliguri. We have a case where there was a senior doctor who had prescribed a MTP kit. Normally, the patients come and they say that, doctor, we do not want the pregnancy, so why do you want to spend money on ultrasound, etc. MTP done, little bit of spotting, similar sort of a scenario. Patient came with collapse and then unfortunately passed away. When the doctor had to actually face a medical legal brunt which went on for almost 2 to 3 years. So that is the sort of scenario that we do not want to fall into. I think it's safer to be on the safer side for us rather than not take calls like this. So I was just, we have diagnosed the ectopic pregnancy. The management part, I'll hand it over to Sneha ma'am, because I'm sure she'll excellently do the management of this case further on. But before that, Indrani ma'am, just one question from one comment from you. Coming from Shillong or this northeastern part where probably sometimes ultrasound is not available in the nights. We, of course, it's not mandatory to do ultrasound to diagnose a rupture ectopic, but medical legally, it's always nice to have a report of hemoperitoneum before you put the knife on the patient on the medical legal ground at least. So, ma'am, how do you tackle this such a scenario if the patient comes in the middle of the night to you in Shillong in your hospital? I mean, I'm sure your hospital has ultrasound, but any of the rural centers over there.
Thank you so much for giving this opportunity. Firstly, I would like to stress on a few more important points here. Like, any patient in the reproductive age group, irrespective of whether she has amenorrhea or not, if she presents, it's ideal that we always do an UPT because ectopic pregnancy can occur without any history of amenorrhea. I think that should be very well kept in mind. Any history of irregular, something like it should strike. That's what my first panelist has also told. You should think ectopic to diagnose ectopic. So irregular periods in the reproductive age group without history of amenorrhea, always do a UPT. And most importantly, when patients present into the emergency in your casualty, usually the MOs in the casualty, they are not obstetricians. They don't think ectopic. And many a times, they will just give symptomatic treatment and the patient goes up and the next day lands up in shock. So I think that is one important point we have to remember regarding the UPT. And now regarding the ultrasound.
Yes, Anima, here I would like to add that the patients are treated for UTI. They have the diagnosis of UTI more than ectopic in their minds when the MOs are treating the patient.
So yeah, it's very important that we train our MOs in the emergency, always think ectopic before you discharge a patient in the reproductive age group, because we've had patients who have gone back and come in shock, the next day. And regarding ultrasound, as you say, Dr. Priyankur, I think patient with an ectopic pregnancy, if she's having hemoperitoneum, then I don't think an ultrasound, because you tap, you put a needle inside and you get hemoperitoneum, your diagnosis is established. If the hemoperitoneum is not massive, you can put a needle in the POD, you extract blood, there is blood inside. Now, considering patients who are a little bit unstable, like stable patients who might not have hemoperitoneum, those also, early pregnancy, bleeding, pain, there's a typical symptom. And when you do her pervaginal, her pharyngeal tenderness, cervical motion tenderness will be positive. So these are things. But before you put a knife, definitely, if you don't have an ultrasound, you will have to document blood. So I think tapping is what is like I would advise, especially, the juniors, they at the drop of a hat, at the middle of the night, they will call the sonologist. Please come and do ultrasound. If they sprang blood, I don't think ultrasound is required to diagnose an ectopic pregnancy.
So the message here is you have to document hemoperitoneum, whether it is by ultrasound or by tapping, right? So
right.
Absolutely.
We agree on this, that yes, this catastrophe is due to some bleeding inside the peritoneum. So very well discussed, Priyankur and Indrani. Of course, your inputs are very valuable. I would just ask you, and maybe I think Dr. Sashibala also we can involve into this discussion. For this patient, would you like to go for, she's already collapsed and, you have already planned for, hurried intervention. So what would you go for, whether laparotomy or laparoscopy?
Ma'am, are you I'm supposed to answer? Yeah. She already collapsed. We'll not waste any more time. We have to clamp the bleeding vessels.
Yes.
It is you or anywhere. We will immediately take up to the OD sometime. We do not wait for the blood also. Because arresting the blood, which is already...
Yes, please, go ahead.
I'll do my open laparotomy. I'll not waste any time in putting where is needle and anything. She's in shock. We have to
Dr.
do
Indrani, do you want to agree to this, or you want to add something?
Yeah, I think I will leave it. If my anesthetist will be agreeing to give a GA and give a GA, then I would put a scope, because we do routinely laparoscopic management. But if the anesthetist says that the condition is too bad, I will not be able to sustain. No, the hemodynamics is not good, then definitely laparotomy. It's actually the skill of the surgeon. Even the lab salpingectomy takes time. If you are skilled, in 15 minutes you can do it.
Taking out the blood requires lots of time. I think that we keep on sucking. Lots of clot is there. Yeah, surgery doesn't take much time. Even the open or even the laparoscopic surgery.
Yes.
But the real part.
Yeah, I think given a
Yes, ma'am.
time, maybe a decade ago, if you had given this discussion, we would have said that yes, open it fast and you catch hold of the bleeding point. But nowadays, with this expert gynae endoscopist and the even the operative facilities, they're so much improved. Immediately, you can even the abdomen full of blood, you can suck immediately and just catch hold of the bleeding point. So it will all depend upon the availability of the expert laparoscopic surgeon, the expertise if they have, and of course the what Indrani has said, the condition of the patient and the willingness of the anesthetist as well. So all in all, it's a situational decision.
Most of the time, actually, the anesthetist will say that I will not give a GA because for laparoscopy you will need a GA or whatever the hemodynamics. They are saying that you have to we will not be able to sustain the laparoscopy.
Yeah.
But
So the discussion here ends for us because the message, important message, what we want to give from this, was it preventable? Was it
yes,
preventable?
it was preventable because
Yes, yes.
the ultrasound should have been done before. That would be a message that MTP pills before you prescribe, you should do always an ultrasound before you prescribe MTP
So
pills.
the message is very clear, even though law doesn't make it mandatory, for the safety of the patient and for the safety of yourself, please do ultrasonography before prescribing the MTP rather than doing it at the late hours of night when the patient is collapsed in front of you, right? So we go, thank you so much, all of you. We go ahead with the second case now. We have this 36-year-old woman, with 7 years infertility. The husband is working in Dubai and she stays in a village. So she conceives with IUI. Now she's under your regular follow up to 24 weeks. You tell her that yes, everything is fine. Even the anomaly scan is good and no worries. So she just escapes for follow up. And at 34 weeks, somewhere in the interior, she reports to a remote PHC where, with pediledema. So her blood pressure here is 176 by 116. Fetal growth is okay, apparently normal, and proteinuria is present. So because the blood pressure is high, the doctor there started tablet nifedipine retard, Nicardia retard. Okay, and he just advised her to get admitted at a higher center. This lady did not listen to him, and after 2 days she got admitted to the higher center, that is sub-district hospital, where she was given added tablet labetalol and magnesium sulfate and steroids were given. Because they had the facilities of anesthetist, she was taken up for cesarean, get rid of it. So the LSCS was done. Baby 1.8 kg live baby was delivered. That time her BP post-operative was between 140 to 180, 100 to 110. With tablet nifedipine, tablet labetalol and Maxil was continued for 24 hours. So Indrani, again coming back to you, because this is written for you, but I would like to involve other panelists. I would come to you. I can see Dr. Jayashree. Would you like to take up this question? Suddenly she started becoming breathlessness. She started becoming breathless, restless. Tachycardia, BP is 220 by 118. Saturation falls down to 70%. Her chest is full of wheeze and there's no clear sounds. What is your diagnosis for this patient at this point of time?
She has developed pulmonary edema.
Correct. So what is, how would you go ahead with the management now at this stage?
First, we will manage airway, breathing, and circulation. We give, if she, her oxygen saturation is 70%. So if her airway is patent, we'll give with high flow oxygen, with non-rebreathing mask, then we'll give Lasix 100 to 200 mg stat.
So you have given her oxygen, you have given her last. What else?
Then we'll try to reduce her BP, as BP is 220 by 180.
Fluids. You want to give her fluids?
No, ma'am. No, we'll try to reduce her BP. We can give her
What?
anesthesia.
Anybody else?
Yes.
You're right. You're right. So first and foremost, you will make her upright, no? Back. You will make her propped up position. You will give her high flow oxygen, as you have said. You will give her Lasix. What for antihypertensives? Yes, Indrani.
IV infusion.
Parenteral.
Yeah. Can we come to you, Dr. Pulit?
Who's supposed to take this?
Dr. Pulit Katita, I can see.
Yes.
Hello, Dr. Pulak.
Yes. Yeah. In this case, yes, is 70% oxygen saturation. Yes, Paul. Already, Lasix is patient's position is important. Okay, we have to give high flow oxygen. Okay. Another important is that probably this patient will need some positive pressure ventilation, probably in the form of NIV also, because some positive pressure. Because all of her chest is full up with fluid. Yes. Regarding blood pressure, it is too high, so injectable labetalol may be a good option in this patient.
Infusion. How much and how you will give? How much? Labetalol. How much you will give? How you will give? You must be using it routinely, I'm sure.
Yes. It can be given IV. First, 5 ml IV can be given. Then we will monitor her. That is 5 ml means it is 100 milligram first. Then we will monitor, and accordingly, if necessary,
Labetalol that is available as 20, 40, 80.
20 milligram per ml it is available. It is
so you will give 20 first and wait for the response. So you directly give 100.
Yes,
I don't.
Give for 20.
We start with 20 or 40. Okay, even according to the Parkland regime and what we are using routinely, we start with 20 ml. Okay, wait for how much time to observe the response?
Usually half an hour, ma'am. Up to half an hour.
It's usually 10 minutes. Okay, so you give 20. Anybody else want to take up this? So it is usually 20 milligram first. Wait for 10 minutes. You look for the desired effect. If it is not there, you give 40. Wait for another 10 minutes. If there is no further desired effect, then you give 80.
80.
Right? So I think
correct. And maximum may be up to 200 milligrams of intravenous labetalol can be given, madam.
220 is the highest dose is 220.
Yes, 220 is the highest dose. So now, Irani, I come to you. We have given her propped up position. We have given her Lasix maybe around 80 to 180 milligram. And then you are giving this, injectable labetalol, giving her high flow oxygen. Then when
patient should be catheterized as well. Patient should be catheterized as well to see the urinary output.
So this patient was, even the anesthetist was called. Things were being done simultaneously, but at the same time, she, she was being shifted to ICU, but she landed up into cardiac arrest. Now, Indrani, how will you? I think Dr. Isaiah, sir,
Yes, sir.
we would like to listen to you. How will you manage this patient now?
Since it's already she has landed with little complications of hemorrhagic. Patient has to be shipped in ICU.
Yes.
And intensivist, I think intensivist has to be called up to tackle this case instead of
But
obstetrician.
then she has developed cardiac arrest. So by the time the intensivists come, how will you manage?
Start with CPR initially. Start with in the ICU till the intensivist or a cardiologist lands up in thing. If possible, you can go for your case.
Okay. So Dr. Kavita, I want you to elaborate on this point.
Now that she has developed cardiac arrest, there are a few things that we should keep in mind because here she has a pregnancy and the CPR that we offer to the pregnant
She has
lady.
already, we have done her cesarean section.
We have already done a cesarean section. Okay. So anyway, the first and foremost thing is to call for help because you will need 2 or 3 members for the resuscitation part. And always remember that no delay should be there in the CPR. Each minute of delay will lead to a 10% risk of mortality. So early CPR and high quality CPR is indicated. And also we can think in terms of defibrillation. So there's a particular order that you have to follow for the CPR method. First is to feel for the carotid pulse. If it is not there, then obviously 2 people have to take up the CPR. So they say that 30 compressions have to be given, and each compression has to be effective. So you have to put your hands, both the hands, at the lower border of the sternum, and then give the chest compression so that the chest depresses by at least 5 centimeter, and with your arms extended at the elbow. Then it is known as effective compression. So every 30 compressions, then you can give the breath, 2 breaths. So 30.
I would like all of you to listen to Dr. Kavita, because she is really expert in this management. Okay, so purposefully we are asking her to brief it. So please, all of you, please listen to her. Yes, Dr. Kavita.
So these compressions, to be effective, you have to give it so that it compresses by at least 5 centimeter, and then give a release. The chest should recoil back because the lungs has to be inflated with the air. So that is what is needed. And earlier it used to be ABC, like airway, breathing, and circulation, but now it has been changed to CAB. So C is compression, then airway, and then breathing, because they say chest compression can be offered by anybody, and it is a skill which can be learned more by bystanders as well. So that is the first thing that we have to do. Then check for the airway. So for the airway, suppose she's not breathing, then you have to tilt the head and lift the chin up, and then give mouth to mouth breathing, or if you have the mask, then you can give with that as well. So these are certain salient points, and once you have to check that the circulation comes back. So if the circulation is not restored, then obviously you will have to give the other medications as well, such as adrenaline and all. But that comes little later. Now, once
what is the role of dopamine, dopamine?
Yes, that can be started also, because here the blood pressure was maintained. That's why I did not mention.
Yeah.
So these are certain points which needs to be looked into for CPR.
Yeah. So all in all, what you have said now, rather than this ABC, we have to change to chest compresses first, then airway, and then breathing. Okay, and then of course, when she's going into hypertension, you have dopamine or dobutamine. Initially, you try and resuscitate first, then you look for the cause. Then, of course, you know, bedside, you give, because it is, you know, the chest is full of the wheezing or the bronchi. So you nebulize this patient. You give her, you know, whatever nebulizer, steroids, assisted ventilation, as somebody has talked it already. And then, of course, then you send your lab for maybe for cardiac enzymes, if at all you need the ABG, the blood gas analysis, and then, of course, bedside X-ray, ECG, and echo. All these things, you know, can be done later on, but by the time you have to stabilize the patient.
Just want to add, ma'am, over here that 30 compressions with 2 breaths is 1 cycle.
Yeah.
So the rescuer who is giving this can do 5 cycles and then interchange.
Correct.
So 5 cycles can be done by one person and 5 cycles by the other. And if the circulation is not restored, then you have to defibrillate as well, and see whether it is a shockable rhythm or unshockable rhythm. But then that is going into too much details. I'll stop here.
Yes. Okay.
I think during this whole exercise, a patient party should be also kept in the loop to what's going on, to be on the safe side.
Perfect. Perfect. They have to be informed time to time. It's not only one time information. So that is deep. You have to brief them all the time. You know, everything has to be very transparent. What has gone wrong and what we are trying to, you know, correct it. So can we ask this question to all of you? What has gone wrong for this patient? Dr. Kevin is not here. So may I have the answers from I think Dr. Sindhubala, you are welcome for this.
Yes, ma'am. This could be preventable because such a high pressure. She was clear-cut case of, like, you know, severe preeclampsia, and imminent eclampsia could have been there. Cardiac arrest could have been there. I rather request my anesthetist to give Lasix, especially if the OT. And fluid management has to be taken care, and if possible, she should be shifted in the ICU just after the surgery. She should not have been operated where the facility of ICU and ventilator is not there, because she could have required all these help any time. Especially like 48 hours is the most difficult part after the surgery. When surgery is done, job is not done till we stabilize the patient, and we always start magnesium infusion even after the delivery. In such a high malignant hypertension, PIH, severe preeclampsia, we start Maxel from the OT.
That she was receiving, that she was still on Maxel infusion. Okay, so for the 24 hours, it was still continued. Okay. So now we go to Apurva sir. Can you throw some light from your side for your expert opinion for this patient, with such a high risk patient, right from the beginning, early pregnancy? Would you like to advise some things?
Biochemical biomarker.
Yes, ma'am.
Yeah. So for this high risk patient, whether we could have, predicted it right from early pregnancy. Would you like to make some comments from your side?
Yes, ma'am.
Yes, as an expert, do you want to make some comments for this case?
Actually, this type of cases, we should always be cautious. You said that during operation itself, we should take care. And another thing is that post-op management should be very care. We should try to rather prevent these type of cases. As the patient was hypertensive, we should always think of the blood pressure to be controlled by antihypertensive, regular antihypertensive. On the second day, it developed. I think after 30 hours, the patient develops some. So this type of should have restricted fluid, antihypertensive to be continued, and proper monitoring should be done. If possible, in a HDU, always in a HDU. So because in now almost all centers, obstetric centers, they have got HDU.
Correct. So I'm sure all of you have discussed the intraoperative and postoperative parts, what precautions you should have taken, for this case. But I'm sure there are many more things which are missed. So I sum up, right from early pregnancy, this patient, look at this case. She's 36-year-old, okay, more than 35. She's an elderly gravida. She was treated as a case of infertility, almost 7 years infertility. She conceived with IUI. So all these high-risk factors we have to take into consideration. We have to calculate risk scoring. She goes into high risk for hypertensive disorders of pregnancy, right? So for this patient, prediction, secondly, prevention by low-dose aspirin and high-dose calcium vitamin D. Okay. 2. Thirdly, she should have been advised, the mean arterial pressure, the uterine artery pulsatility index, the PLGF and SFLT, all the biophysical and biochemical markers for prediction of hypertensive disorders during early pregnancy itself. That is a period where 11 to 13 weeks, right? All of you agree to this?
Yes, ma'am.
Then let this patient, at 24 weeks, I'm sure this obstetrician has not looked for all this, uterine artery pulsatility index and all these things. They have missed. And that's the reason. That is why they said everything is fine. So that's the reason the patient, lapsed from the follow-up. Otherwise, if the obstetrician has told this patient that, no, you are a high-risk woman, you're going to develop hypertensive disorder, which can be serious enough. So she would not have missed for follow-up, correct? Once, when she was diagnosed as having hypertension 176/116, it is a severe hypertension, significant proteinuria, all these things. So for this patient, oral tablet nifedipine retard is not a drug of choice. For severe hypertension, I'm sure all of you will agree, either it should be injectable labetalol or it should be oral capsule nifedipine. I'm sure. Dr. Sindhu Bala?
Yes, ma'am.
So drugs which are, used for this mild hypertension, for this severe hypertension was absolutely wrong. Tablet nifedipine retard is a drug for non-severe hypertension. Even when she went to the higher center, then she was added with tablet labetalol, that even when the blood pressure was so high, that is severe hypertension. So here again, they missed it. Next, when you have to take up this patient for, any operative intervention, you preload the patient, right? Indrani, I'm sure you will agree to me that the anesthetist asks you to preload, this is a patient where you have to restrict fluids.
Yeah, fluid restriction was not managed post-operatively.
So for this patient, the preload should have been little restricted. And the moment you deliver the baby, a strict no to methergine, or if at all, at some facilities they use methergine. So strict no to methergine. Of course, yes to carbetocin. And if at all you are using pitocin, it should be a concentrated infusion of pitocin. Okay, the oxytocin 20 units, small, little fluid with 20 units in oxytocin. This should have been the management. And of course, the moment the baby is out and she is in the third stage, and of course the observational stage, that is the fourth stage, we should have given her injectable Lasix, right? Do you all agree to me?
Yes, ma'am. Yes.
So this is how this patient was mismanaged and missed, I would say, right from early pregnancy. She was not screened properly. She was not suspected to have, hypertensive disorder. She was not detected early and she was mismanaged. That is why we have landed up into this complication of pulmonary edema. And one single mistake of, we could have prevented this. That is what we have to realize. So that is why the retrospect or introspect ourselves that whether this could have been prevented. Okay, so thank you so much, Indrani, Sindhubala, and Dr. Pulak. So,
Yes.
And thank you so much, Kavita, for your wonderful inputs for CPR. I'm sure people have really got the expert opinion about the 30 compresses. The chest should be compressed to 5 centimeter. It should rebound back, and for every 30 compresses, 2 breaths. That is a 1 cycle. That is how I'm sure they are benefited with this. So, Dr. Sindhu Bala, we come to you now with this patient. You have 20-year-old primary, 9 months amenorrhea. She was, hospitalized at some small nursing home nearby from 3 p.m. onwards, almost up to 11 p.m. So for 8 hours. And she was in labor before 3 to 4 hours prior to this admission. So almost 12 hours. Okay. So she was not progressing. So she was decided to be taken for cesarean section. So when the nursing staff tried to catheterize the bladder, she could not get the urine. And then when she inquired further, maybe since admission, she has not passed urine. Okay. So so she was referred to the higher center now. Here the pulse rate was 110, BP was 110/70. Uterine contractions were so severe that there was no relaxation in between. Severe in intensity. Fetal heart was 100 to 120. I'm sorry, this dilatation is 3 centimeter only. Membranes absent. And there was little, blood stain discharge coming, blackish discharge. So what is your diagnosis, Dr. Sindhuvala?
Ma'am, this is a severe case of severe abruptio placentae.
Yeah.
And since this patient is not passing urine, she could have got into already ARF, or could be compensated stage of shock.
Correct.
And at the same time, she is having fetal distress also, anemia also.
Yeah.
Coagulopathy
We provide you the investigations. When we investigated her bed, then HB was only 8, platelets were 1 lakh, her PTINR was 2, and hepatitis was prolonged. Okay, she has fibrinogen only 150 mg%, and FDP were present. Now, what is your diagnosis?
Coagulation phase.
She abruptio with impending DIC also, and she will really need multidisciplinary approach of management, which our madam has said in our Mane madam has said in detail. You have to involve all the departments, including.
So she has abruptio placentae. What all things? What is your final diagnosis?
Yes, ma'am.
HELLP syndrome.
Abruptio placentae with DIC. DIC is a part and parcel of abruptio, ma'am. I have seen it in my residency, both in junior residency and senior residency. Odd part was her BP. I do not know why BP is maintained. BP should have fallen. Usually such patient land up in shock also.
Yes. Hello? So she has abruptio placentae. 1, agreed? She has abruptio placentae.
Yes.
She has landed up into DIC. She has landed up into acute renal failure. Don't get missed by this blood pressure of 110/70. This must be the hypotension for her. She must be initially severe. received, maybe, because now she has
Maybe.
landed up into ARF. So you can retrospectively say
Yeah.
that, yeah, she's in hypovolemia at least. Okay. If not hypotension, maybe she's in hypovolemia. And of course,
Hypovolemia.
FTP, yes. So what are all things? You have fetal distress. So my question to, I think we can pass it on. Dr. Pulak,
Yes.
whether you would do cesarean section immediately for this fetal distress? She's
First,
not progressing. As dilatation is only 3 centimeters, she's not
yeah.
progressing. She has all these complications. What would
Yes.
you like to do? Arrange for blood and blood product first, or like to go for, you can't wait. She's already in fetal distress.
Yeah, we have to at the same time we have to arrange blood and all these things. We have to. It will be a multidisciplinary approach, but most importantly, we have to terminate the pregnancy. We have to immediately deliver it. Immediately, we have to deliver the baby.
Yes, but how immediately? Whether you want
Before that, we have to correct fluid. Proper fluid management is very important because she is having severe hypovolemia because of abruption. So that has to be corrected. After that, probably she will need cesarean section has to be done.
Hypovolemia, I agree with you. You correct, you do fluid resuscitation, but then she's into coagulation failure.
Yes.
This patient, can I take this answer?
Yes,
Ma'am,
yes.
This patient party will need to be thorough counseled regarding the steps of management and thorough recorded audio visual counseling if we have to protect ourselves from later litigations or anything. And
yes. Please go ahead, Dr. Sindhuwala. We are eager to listen to you. How will you counsel your patient?
Ma'am, we do have a facility of audiovisual recorded counseling facility. We have to explain the risk which can happen during the cesarean section. That is like atonic PPH. I have seen patient going into atonic PPH. Even if we did hysterectomy, patient landed up in DIC, and then she required many days in ICU and ultimately died. And then patient filed a suit against the doctor in the hospital. And so this has to be informed that we might not be able to salvage everything. Like patient, we might lose the patient, we might lose the baby, we might have to lose the uterus, and we have to arrange, of course, everything simultaneously has to be arranged, but we don't have to jump to the cesarean immediately without getting everything in hand.
So everything has to be simultaneously. You resuscitate the patient, arrange for blood and blood product. Your team will counsel with the patient and relatives and take a detailed, informed written consent. I add only one point to your discussion, Dr. Sindhubala, that you have to take it in writing from that patient's relatives that this is a condition in which the patient has come to us. So from here onwards, we will try our best, but what damage has already happened has happened. So we have to, correct that first and then try our best.
Yes.
Senior gynecologist has to be called on.
Yeah. Yes, sir. Please go ahead.
Senior gynecologist should be on the team. So
yes. So naturally, senior gynecologist, senior anesthetist, the team may be NICU, of course, and then blood and blood products. And then, of course, if you are well versed with the, management of PPH and obstetric hysterectomy also, well and good. Otherwise, do not hesitate to, call for help from your obstetrician colleague as well. That is what the message is. This is just a theoretical discussion. All of you know this, but here you have labor, fetal distress, DIC, hypovolemic shock, acute renal failure, all in all to be managed for this single patient. Okay, so all of you have discussed it very well. Only thing is, whenever we have to take this patient for cesarean section, be prepared that this patient who has had abruptio APH is very, very prone for going into PPH. Correct?
PPH.
Yes. And that's the very reason you have to take this forward and you have to discuss with the relatives. Do not relax when the baby is out. Try and give prophylactic, utratonics, maximum possible. You try balloon tamponade or compression measures, whatever you want to give. You have to observe, do then and then only. Do not relax for this patient even for first 24 to 48 hours. Okay. So management of the fourth stage, very, very important for this patient. Then of course your blood and blood products will continue. The discussion will go on and on. So we come to you, Dr. Isaias now. Sir, this is a patient for you, 32-year-old para-1 previous cesarean section. She's a male child, only 1 year old. And she came to you during 6 months of her pregnancy because the husband got job transfer to your city. She came to you for bleeding PV. So by the time she reaches the hospital, the bleeding has stopped because it was only spotting. Then on further inquiry, then hurriedly you did her ultrasonography that suggests 26 weeks pregnancy, placenta previa, etc. When you ask her, then she tells you, yes, early pregnancy also she has had little spotting and the ultrasonography report was showing low-lying placenta. Okay. So at 26 weeks, when you do ultrasonography, you find that, there is absent RP leg. The anomaly scan is normal, no normality detected. So this patient, at follow-up 30 weeks again, suddenly she started bleeding at home significantly. She came to the hospital, again it stopped. But while you advise her all the investigation, she collapsed in the hospital itself. What is your diagnosis and how would you manage this patient?
Since she has a history of repeated bleeding and past history of cesarean section.
Yes.
It may be a case of invasive placenta also, or low-lying placenta.
Low-lying placenta, yes, placenta previa and
Placenta previa.
And yes,
might
the
be invasive one, maybe. It
Yes,
may be invasive placenta, maybe. It may be percurator,
So,
maybe percurator.
Yes. So, how would you manage this patient from this stage ahead?
Okay. First, patient has to be just very high risk case. Team effort has to be done has to be discussed with our senior colleagues also. All has to be called in. And before taking the patient, because since it's an invasive placenta, so surgical intervention is required. So party has to be informed initially about the party and the thing about the possibility of the complication that might arise out of this surgical intervention. Blood product has to be kept in touch. Patient must be informed if required. Patient might have to go for hysterectomy or cesarean hysterectomy might be required. Extreme case required situation might be.
Correct.
And then
so this patient now you have to I think can you see my screen?
Yes, ma'am.
Okay. So now
it's not full screen. It's not full screen. The slides are not full screen.
Yes, because I had power failure in between for a moment. Okay. So that's the reason I thought I got disconnected also. Okay. So I hope you can see the screen now, full screen.
Yes.
Okay. So how would you manage now this patient?
First, the surgical intervention, as I said, surgical intervention is very required to manage this case.
What intervention? How would you how would you discuss with the patient and relatives what management she will require?
Yes, ma'am. Patient has to be told beforehand that continuing pregnancy at this stage only might require with risk for her also as well, because she has a having on and off and she has collapsed also. So in that case,
so this is only 30 weeks, so termination, previous seizure, 30 weeks, placenta.
Yes, ma'am.
You have to take her.
Patient already had collapsed and a patient has already collapsed. So continuation of pregnancy might be risk to her life in future. In that case,
I don't think we should think of. She's already collapsed in front of you, so we can't think.
Patient has to be resuscitated first. That is the first thing. At the same time, party has to be informed what's going on, what's the complication she has come across, and the resuscitation has to be carried out as usual. As I said,
what else? What else? Resuscitation is okay because she has collapsed in front of you. But what is the plan of management? What is the plan of management for this patient? We are already, you said surgical intervention. What surgery you want to plan? What do you want to inform the relatives?
Relative has to be told that since only 30 weeks pregnancy, Viability of baby is not possible, may not be possible if at all.
Correct.
And in that case, an extreme step, she might have to go for obstetric hysterectomy as well, if required. The patient has to be informed about that possibility as well.
What else? You have said it about the baby, correct? Yes, because that is that to such a moribund woman also.
Viability is not possible.
Yes.
Extreme is that obstetric hysterectomy. She might have to lose the uterus. That in that case,
but
blood has to be
even beyond that. What she might require massive transfusion.
Blood
products.
Yeah, yes. All this has to be.
They themselves have their own problems of blood reactions. She may or may not tolerate that. Because of that also she can land up into trouble. She can be serious anytime. Already she's in such condition. So everything has to be informed and taken down as an informed written consent. Do you tell them that we are taking her up for cesarean section, or you take a consent that we are taking her up for cesarean section with hysterectomy?
Cesarean section with hysterectomy.
Yes, this consent is very, very important. See, nowadays, I'm sure all of you are listening to the talks, and people have managed hundreds of cases with conservative management, that is uterine conservative surgery. Yes.
Yeah.
Few years ago, maybe 2-3 years ago, we used to say that, that it has to be an elective obstetric hysterectomy. It shouldn't be an emergency. Because when the patient is prepared, the relatives are prepared, and you are well-versed, well prepared with your team. Okay. But nowadays the concept is coming up that if at all she's a primey, or maybe she wants to have further child, maybe some women, in spite of completion of the family, they don't want to remove their uterus. So in this case, maybe you have to go for uterine conservative surgery, but from the relatives, when you're taking a consent, that you have to take a consent of hysterectomy, because in life-saving conditions we have to go for this. That is how the consent should be taken. That is about the consent. So first thing is you will arrange for blood and blood products. Secondly, you have to go for the informed written consent. Thirdly, your team. Who all should be there in your team? I think Dr. Kirtan has left for emergency. So I can ask other panelists. Dr. Pulak, yes, please.
Yes.
Anybody can take up. Pulak, you can comment on this. Yeah.
Regarding what, madam?
Who all should be there as a part of your team for this operative procedure?
Yes. First thing, some senior person has to be there. Okay, senior obstetrician. Regarding. Besides that, the possible complication, some surgical complication may happen. Most likely bladder injury, bladder and ureteric injury. So bladder injury, for if availability is there, you can urologist should be informed. If urologist is not there, at least surgeon should be informed. Okay, he should be there. And
so is it for only bladder injury you want to take the urologist or something else?
Ureteric injury is one important.
Yeah, so you may have to stent the ureters.
Yes.
You may require some, repair of bladder or something. And also, for this perforita, sometimes you need extensive resection. Okay. So that is why you need to have a detailed knowledge of the pelvic anatomy also. And that is why you need a surgeon or a urosurgeon or an oncosurgeon, any one of them. Okay. So you need a senior obstetrician. You need a senior anesthetist. You need surgeon, oncosurgeon, or urosurgeon. You need a blood bank. And of course, neonatologist. Who else? 4 people. 2, 3 people. You want to have some, intensivist with you. Blood bank should be, available.
There should be a massive transfusion protocol should be there in the hospital. That is most, that should be activated. Massive transfusion protocol.
So all these things, have to. And one more person I would stress, if the facilities are available, that is interventional radiologist.
Yes.
So, Dr. Kavita, do you want to make any comment on this from your side?
Regarding intervention is there, then we may think of uterine artery embolization.
Yes.
Okay. That help us to reduce the blood loss.
Correct. Even beforehand, you can do that.
Yes. Beforehand also we can.
Yes. Nowadays people have that concept of, aortic balloon.
Yes.
So many things are coming up. So you may have to go for, interventional radiological procedure that will help you in reducing the blood loss also. So all these things. Okay. So I would go to now Dr. Indrani. Indrani, what precautions you will take for this surgery, before this surgery? Do we have Priyankur here? Priyankur? Yes, Priyankur? Okay. So we can continue. No problem.
Precautions in the sense like prior to surgery, you mean? Because she's
yeah, prior to surgery, we have prepared the patient now, everything. Before, you have taken her for surgery. So right from the incision, the abdominal incision, the uterine incision, all these things.
So, because we know that we are expecting a huge blood loss, a massive blood loss for her, we try to minimize.
Anything for the fetus you want to do? Because it is only 30 weeks. Now you can't do anything, right? Yes.
If it was prior, so maybe steroids would have helped.
Yeah, that we'll go to introspect. Okay. So go ahead with the discussion.
So if this was not a patient who's already collapsed, then maybe prior.
We will talk about it later. Idrani, now you have taken up the patient in operation theater. Now, how do you want to start with the incision?
So incision wise, depends on how you're comfortable, because she's a post-cesarean case. What the scar is, if you feel the transverse scar and you're confident, then you can go ahead with the hysterectomy. With the transverse scar, you go ahead. If you're not confident, because you anticipate you might go for a longitudinal.
Only thing, it should be a liberal incision.
Liberal incision.
Give you good exposure, right?
Yeah. Try to minimize the blood loss from the beginning, because anticipating more blood loss, each point you try to ligate and go inside. And once you reach the uterus, after you deliver the baby, if it is actually adherent placenta.
How would you take the incision on the uterus? That is the main question.
It's an upper segment, because it is an adherent placenta.
Vertical upper segment.
Upper segment, cesarean section. Leave the
classical vertical cesarean section, because it's low-lying placenta.
And then with the placenta in situ, I will go ahead with the hysterectomy, because it is a placenta percreta syndrome.
So the incision on uterus, that is what to be only specified. That is, it should be a upper segment vertical incision, like a classical scissor, or maybe a transpundal. Okay, if you want to go for a transverse, it should be transpundal. That means at no point of time you should cut or incise the placenta, right? Otherwise, that will start bleeding. Correct? So you deliver the baby, and just apply the green Armitage or whatever compressing clamps you have, and then go ahead, with the hysterectomy. That is only clamp and cut. Don't wait for ligating, okay? So that whatever bleeding organ you remove first, and then you go ahead with the securing the pedicles, right? Anything else you want to, anybody wants to add? Yes, Dr. Jayashree, you want to add something here? Going for this procedure, you can go for stepwise devascularization.
Yeah, stepwise devascularization usually we follow.
Okay. Anything else? Anything else remaining here? Okay. Now we come to retrospect. Okay, to introspect yourself. Was it preventable? Dr. Pulak, I want to know from you whether we could have given the cervical stitch for this patient. Could we have given the tocolytics? Yes.
Yeah, definitely. Tocolytic is a controversial, ma'am, because tocolytic many a times, especially beta-mimetic, should not be given.
Basically, there is no role for this patient. There is no role of tocolysis. Patient doesn't have uterine contractions. So why do we want to use tocolytics? That is one. And secondly, just giving it empirically has its own side effects. Okay, so long-term tocolysis is definitely a no-no. If at all you want to give tocolytics, it will be only for a shorter duration, that is maybe 72 hours maximum, till the time your magnesium sulfate or your steroids act, right? You are trying to, even at 30 weeks, suppose you feel that, this patient may land up into any complications. So you need to prepare the baby. So antenatal steroids and antenatal magnesium sulfate for neuroprotection, correct? So for the baby, you keep the baby prepared so that you can, if at all she lands up into emergency, how she has landed up here, you can, definitely take care of it, correct? So prophylactic fast tightening, a strict no, because for fast tightening, now we are very sure it should be cervical length of less than 2.5 centimeter. That is a cervix. That is even Foxy, Figo, and all the organization, they recommend that only for short cervix. That too, they say for short cervix, even the vaginal or micronized progesterone, they act equally well as comparable to the cervical cerclage. So even for them also, there is a not a must. So cervical cerclage is not a must. But for short cervix, yes, it is justified. It is indicated. For this patient, it is not indicated. And tocolytics, a strict no. Only thing is precautions. Definitely, this patient should have been diagnosed at the earliest. 11 to 13 weeks itself, you can diagnose. If you find, anytime you find that, the gestational sac in the lower uterine segment, or you find that the myometrium interface is lost, or you find that the blood sinuses, they are crossing into the myometrium, you find the lacunae, laminae here, the placental sinuses, you can see multiple vessels crossing over the bladder to the myometrium also. So myometrium to bladder, that interface is also lost. So this is, it should be suspected at the earliest at 11 to 13 weeks. If not diagnosed, then at least RCOG also recommends that even when you are doing your routine anomaly scan, that point of time also you can, look for the localization as well as the absence of the RP leg. That time, at least if you label it as, placenta previa or accreta, then this patient should be hospitalized or offered, a very cautious care, and this patient should be hospitalized. Blood should always be, reserved, and she should be asked to avoid all the strenuous work, intercourse, internal examination, all these things. So for this patient, she was not hospitalized. Okay, correct?
Okay.
So that is how, yes, let me know. I can hear you. Please go ahead. Please go ahead. Somebody wants to add something? Yes, Apurva sir, you want to add something?
Actually, this is a very serious case because she came for checkup, she had bleeding, and somehow it should have been detected. At least whether it is a placenta accreta syndrome, it is a Parkita, or that should have been done.
Yes.
That is missed. Secondly, she collapsed. Whenever she collapsed, actually, in these cases, very expertise requires. Whoever knows all the techniques of hysterectomy, taking out the baby, hysterectomy, even bladder dissection has to be done. We are getting a lot of cases of placenta accreta syndrome here, and especially, as you say, devascularization. You should know how to ligate, how to take care, ligate the uterine vessels, uterine internal artery, and total hysterectomy is the answer. Not partial hysterectomy will not, because if you go for subtotal hysterectomy, the patient may bleed again. If the cervix is even kept, some part of the placenta may bleed. And in that case, we'll have to always think of complete hysterectomy. And this type of cases nowadays should always be, we should do a very good ultrasonography or MRI to rule out accreta parkita. This was missed somewhere. I think it should have been done in a, the patient may not be in the, maybe in the periphery. That is another center. So this patient should be always taken care, and there is a question of life and death.
Yes.
We may miss the patient at any moment. We should have a very good team. We should have a very good counselor. At least we should counsel, hurriedly counsel, and take consent. Hysterectomy, even table death consent also taken. Even in the ectopic case, sometimes we take table death consent. You have to do. But as soon as you stop the bleeding, the patient may survive. In that case, you have to give the blood components. So I think you have you have put up very interesting cases. Thank you, Dr. Sneha. And Dr.
Thank you, sir. Thank you, sir. Thank you so much. In fact, this
And when the patient is sent,
please go ahead.
when the patient is asked to go for ultrasound, I think we should request the sonologist to have a special look into the
high index of suspicion. Correct.
Special look into
this slide is for that previous cesarean section, especially, or any scar on uterus. You make a suspicion that, specially look for, that is what I said, localization of placenta, and specially look for the retroplacental lake of, sinuses. So that vessels, you have to, the sonolucent zone, whether it is there or no. If it is a loss of sonolucent zone, then you have to be, your eyebrows should be raised, and you have to label it as whatever placenta accreta syndrome, whatever type.
Invasive placenta.
And it's not a question of periphery, I would say. Ultrasonography done by an expert sonologist, by a good resolution sonography, gives you very, very accurate diagnosis. It has laid beyond doubt that MRI is not necessary for confirmation of the diagnosis, only for morbidly obese women or the placenta which is posterior placenta. So I think ultrasonography should be good enough, and this is what special precautions during surgery. Indrani has said it very well. That if here what I was talking about is the uterine artery embolization or the aortic balloon nowadays people are doing. But you have a very good clamp, what is called as aortic clamp by Dr. Pailis. So that clamp is like this, see, and it fits into the curve of the aorta, and it compresses it very effectively. If you don't have that, naturally you ask your assistant to compress the aorta and go ahead with the procedure fast. Almost 85% of the blood flow is reduced there, and once you remove the bleeding organ, I think things should be sorted out. That is what the message here is. So one single mistake of ours can, create chaos. It can lose the patient's uterus, and it can, she may even lose her life. So that is what the message is. How to manage the coagulopathy, that itself is a separate topic. I think the massive blood transfusion protocol, we will have to take one more panel discussion here. But I think we will go for one last case here. Indrani, should we go for this case? Yeah. So, Gravida 4, three abortions. 3 abortions for 5. So 2 MTPs and 1 missed abortion. She has last childbirth 7 years back, normal delivery. Antenatal record is absolutely uneventful. The patient was admitted in active labor at around 11 p.m. She delivered at 4 a.m. She delivered by 4:40. She was managed with active management of 3rd stage of labor. By 4:40 also the placenta did not come out. And suddenly you find that she is in full of blood and she's in hypertension. What is your diagnosis? Just quick message. What is the diagnosis? How will you treat this patient?
So in this case, the placenta is retained. As you have said, the placenta has failed to deliver. So firstly, she might be a case of retained placenta who's come in shock.
Yeah.
Or there might be uterine inversion also.
Since she has a history of 2 MTPs, there might be a case of invasive in placenta accreta also.
Correct.
That's a
yes.
Accreta, and so as a result of AMTSL, patient has gone into uterine inversion because of that.
Okay, I think AMTSL will not lead to uterine inversion, but it's a mismanaged 3rd stage.
Mismanaged.
Yes.
Yeah.
The unnecessary traction before.
Might be placenta, because the placenta is so with adherent placenta or not, that is the next step, but definitely it's a case of retained placenta.
Yes. Okay, so how will you manage this case? That is a question. Here we have this diagnosis of uterine inversion. So when you examine this patient, you find that uterus is not palpable. Locally there is lots of bleeding and a fleshy mass here like this. So uterine inversion. How will you manage this case now, Indrani? Quickly.
This has to be managed. We will put her in the OT actually. This done in the OT. And then this is with your fist, with your hand. You have to put oxytocin infusion, and then you have to push the uterus, and whatever you get the cervix, if the inverted part, you have to push your hand inside, and it takes a lot of effort. Like verbally, what I say, it is not that easy. But I have done couple of cases. and with good support bimanual, and you push your hand inside and keep on giving the infusion oxytocin also, and then you can feel it. Your hand just goes inside and like practically.
Okay. So if it has, Indrani, if it has happened in front of you, you can do that immediately. You can repose it. That too, you have to catch hold of the fundus. But then the part which comes last, the part near the cervix, that comes last. So that you have to slowly push inside first, and then the fundus goes inside. Then you keep your fist inside, and then you give the uterotonics.
Effort pressure.
Before that, if you give the uterotonics, that will throw the uterus and fundus out again.
Like if it's an acute inversion, you do it immediately.
Without anesthesia.
Subacute of then there are procedures to manage that. Like you take her to OT, and maybe you can do hydrostatic. You can do that, or otherwise you can do laparotomy and then do a Halton's method and correct.
Yeah, so I think this is the last case. Only this has got a very good message to be given, and that is why I want to discuss this. Dr. Sindhu Bala, this is for you.
Ma'am, may I know what was the question, ma'am?
No,
So
I am
sorry.
just reading it out for you. Only
Yeah,
I
yes,
have
ma'am.
to tell you that this is a case for you. So this
Yes, ma'am.
grand multipara, she was admitted in emergency ward at 11 p.m. with an obstructed labor. Okay, vitals are normal. With antibiotic cover, she was taken up for operative was otherwise uneventful, with only little extension to one side, which was managed very effectively. There was no internal bleeding. The hemostasis was achieved. Everything, the count was good, and she was closed. And it was not at all a significant bleeding. Only little extension to one side that was taken care of. So when the patient was shifted to ward in good condition, after an hour or so, you find suddenly her blood pressure is 80 millimeter of mercury, pulse is steady, disturbed, and she confused look, drowsy. She has a vomiting tendency. Okay, when you examine, you find that abdomen is otherwise soft. There is no external bleeding. And the uterus is well contracted. What is your diagnosis? And how will you?
Yes, ma'am. This points to only two conditions. It is either just like this case, she was grand multipara with a big baby. She could be a case of amniotic fluid embolism. And this is one of the rarest condition which happens to the patient. And it sometimes turns out to be very difficult to diagnose and yet very difficult to manage. Most of the time, it remains undiagnosed only. It's like, retrograde diagnosis that once we have recovered all the managing part, once we are out of it, then we realize she might be case of, like a fluid embolism. Or second option could be pulmonary thromboembolism, which is less likely, but it could be also one of the possibility. But management in most of the cases are same. She needs respiratory support, she needs vasopressors, and she needs.
Okay, so I think I interrupt you here, my dear. Her blood pressure is 80, but her respiration is good otherwise. Little disturbed. Chest is clear, and there is no pallor. Okay, there's no pallor also. So do you think this is still a case in amniotic fluid embolism or fluid embolism? It will be a cardiorespiratory arrest.
Yes,
right? Yes. So this is not so. This is not so. This is a very googly question in this case, and that's the reason but very simple, and that's the reason I want to take it. I don't want to miss this.
Severe, ma'am? Cerebrovascular accident? Cerebrovascular accident? No?
No. Very simple case.
But
Anybody?
uterus is well retracted. She doesn't have.
Ma'am, septic shock.
Dr. Pulak, no.
Septic shock.
Yeah, you are thinking good, but no. We have. She's not prolonged. I mean, she is a case of obstructed labor, but not handled. She was in hospital. She's been given, good antibiotic cover with.
Oh, ma'am, she's actually bleeding from her somewhere from her uterine incision or some extension.
I told you, abdomen is very well soft. She doesn't have pallor. She doesn't have evident hemorrhage from anywhere for that matter. Uterus is well contracted.
Proper fluid replacement has not been carried out because she is already
Sir,
maternally exhausted.
I just, I mean, I just humbly submit that with antibiotic and fluid resuscitation, the patient was taken up for cesarean section. Anybody, Dr. Pulak, Indrani, should I?
Is it like something because she's a grand multipara obstructed labor, prolonged labor, some hiatus hernia or something can happen?
I said very, very simple. Okay. So all these things you will do. I'm sure all of you are expert. We are not going. See the bedside investigation. Hemoglobin is 10.8. She's not bleeding it. See the blood sugar very high. And see the urine. So
Diabetic ketoacidosis.
yes,
Diabetic ketoacidosis.
only one word I want to say: non-hemorrhagic shock.
Yeah.
Okay? Non-hemorrhagic shock. And this case,
Baby is a full
purposefully, I don't want to miss, even if it is late. I'm so sorry. I'm hanging you out here, for such a late night. But this is a case with, we obstetrician, we have to take this message with us that every pregnant woman during every pregnancy should be screened for GDM, should be screened for hyperglycemia in pregnancy. One simple test of single step 75-gram glucose, OGCT or OGTT, whatever you call it as. Okay? Isn't that interesting, Dr. Sindhu?
Yes, ma'am, it was very challenging. I could have, because we do routinely sugars in all the patients. You could have eventually caught, but thinking that DKA is a distant in our brain.
I stopped sharing my screen because, I just see high-fi management, all of you will do. I'm sure you will all call for help. You will all call your anesthetist, you will call your physician, you will call your intensivist, anybody you can call. But this is such a simple, first thing is the, screening for diabetes. Okay. That could have avoided all these things. Even she would not have landed. She has had one, previous one normal vaginal delivery. Because of this sugar, she landed up into 4 kg baby. Okay.
Yeah.
And because of that, she landed up into obstructed labor and cesarean section. That is one. Secondly, when you are doing the, bedside investigation, sugar is the first thing. Hemoglobin, bedside, so bedside investigation still has its own place. That is what I want to tell all of you senior people from medical colleges. You are here. I'm sure everybody will agree that clinical acumen and simple bedside tests still have their own place in this era of gadgets and advanced technology. So the message is very, very loud and clear that our clinical acumen and having a high index of suspicion, going methodically, screening for very common disorders, that prevents all the complication. Managing those complicated patients with such a multidisciplinary team and then taking a credit or losing your patients and burning your releasing your adrenaline so much, I think it's not worth it. So the message is very simple: go methodically, screen everything, and go as convenience. I can see my dear friend Dr. Priyankur. I'm sure you definitely have some messages to be given to the panelists and our attendees. So we would like to have it from you, and then we conclude.
Thank you so much, ma'am. Yeah, so that was a brilliant panel. I was just listening to the whole thing, and it was brilliant cases, well taken actually, with good messages. I would just like to say one thing, two things rather. One is to be prepared, because anything in obstetrics can happen at any point of time. So preparedness is something that we need to always remember, because as we say, prevention is better than cure. It's the same thing that works with obstetrics. And second important thing is, the most important I would say is, in addition to saving the mother and the baby, we have to make a point to save ourselves as well. So medical legal documentation of everything is something that I would definitely want to stress on, because we do try and do the best for our patient to save them, but ultimately at the end of the day, what we forget is to document everything, and that's why we land in trouble. So please document everything, and that will, in addition to saving the patient, will save you as well. So thank you so much once more, Sneha ma'am, and I would once more reiterate the appeal that I made at the beginning. Kindly to support Sneha ma'am, because she definitely deserves to be there. Thank you so much once again.
Thank you so much, all of you. Senior, respected Dr. Apurva Bhattacharya, my
Thank
expert.
Thank you, Dr. Sneha. Best wishes. Best wishes to you. We'll be always with you.
Thank you so much, sir. I thank all my panelists, Dr. Ayaz,
Thank you, ma'am. Thank you, ma'am.
All my panelists, Indrani, Kirtan, Jayashree Goswami, Sindhu Bala, and of course, Dr. Pulak. All of you have, contributed wonderfully, and I'm sure it's going to help many of our attendees also. Thank you so much. And once again, as Priyankura has already made the appeal for me, and I thank all of you. Please do support me for my candidate.
Sure.
I'm one amongst you, and I wish to go ahead with all your support. Thank you so much.
Best wishes, ma'am, for your future endeavor.
Best wishes. Thank you. Best.
Thank you, ma'am.
Good night. Good night.
Thank you.
Good night. Good night.
Thank you, ma'am.
Thank you. Thank you, all of you. And yes, Indrani, Satabdi.
Thank you, ma'am, and all the best.
Thank you, dear. Thank you so much.
Thank you, ma'am. Wishing you all the best.
Wishing you all the best, ma'am. Thank you so much. Lovely webinar and very enrichful discussions.
Yes, beautiful cases.